இருக்குது. முடியல தலைவர்.
எப்படி இருக்கீங்க?
நல்லா இருக்கேன் சார். நேற்றுக்கு தான் ஸ்ரீரங்கம் போயிட்டு வந்தேன்.
எங்களுக்கு சேர்த்து வேணுங்களா?
ஸ்ரீரங்கம் 2 நாள் ஒரு உபநயனத்துக்காக போனேன். போயிட்டு நைட்டு திரும்பி வந்தேன்.
ஓகே.
I'll keep quiet from now on. வணக்கம் ரமேஷ் அவர்களே. லாஸ்ட் வீக் பார்க்க முடியல உங்களை. ரமேஷ், லாஸ்ட் வீக் உங்களை பார்க்க முடியவில்லையே, தரிசனம் கிடைக்கவில்லை. சிதம்பர ரகசியம் என்ன?
அன்மியூட் சார், ரமேஷ் சார் அன்மியூட்.
லாஸ்ட் வீக் எங்கேயா போயிருந்தீங்களா சார்?
ரமேஷ் சார் அன்மியூட் பண்ணுங்க.
அவர் என்னிடம் பேச பிரியப்படவில்லை
சார். இல்ல, அவரு மியூட் பண்ணிருக்காரு.
சார், குட் ஈவினிங் சார். சீனிவாசன் சார், டாக்டர் ராஜேந்திரன் சார்.
லாஸ்ட் வீக் என்ன சார் மிஸ்ஸிங்?
குருவாயூர் சார்.
ஓகே.
சார்க்கு
குருவாயூரப்பனே அப்பன் பாடிட்டு வந்தீங்களா?
ஆமா சார், ஃப்ரைடே போயிட்டு மண்டே தான் சார் வந்தேன்.
வெரி குட். நான் நேற்றுக்கு ஸ்ரீரங்கம் போயிட்டு வந்தேன். முந்தா நேற்றுக்கும் நம்மெல்லாம் வயசான காலத்துல திவ்ய தேசங்கள் போவோம்.
கரெக்ட். ரொம்ப நாள் போகணும்னு ஆசை. நான் கேரளாவில் இருக்கும்போது போயிருக்கேன் 2-3 தடவை.
ஆமா, தேங்க்ஸ் சொல்ல வேண்டாமா? ராஜேந்திரன் நம்மள ஜட்ஜா போட்டிருக்காரு, வாரம் கத்துக்கிறோம்ல, அதுக்கு நன்றி தெரிவிக்கிறதுக்காக போனேன்.
சார், நம்ம இது பண்றீங்க சார்.
சாட்டர்டே இருந்தா சார் ஞாபகம் தான் வருது முதல்ல காலையில எழுந்த உடனே.
எனக்கு டெய்லி ராஜேந்திரன் ஞாபகம் உண்டுப்பா. அவர் கிட்ட ஒரு புன்னகையை பார்த்தாலே எனக்கு ஒரு சார்ஜ் லெவல் அதிகமா போயிடும்.
எல்லாம் முடிவு பண்ணிட்டீங்க.
நான் விளையாட்டா பேசுறேன்னு நினைக்கிறாரு. இல்ல நான் அத பேசினா விளையாட்டுத்தனமா பேசுறேன், குழந்தைத்தனமா பேசுறேன்னு நினைக்கிறாரு.
சீனிவாசன் சார், நான் கேட்கறதுக்கு கேக்குதா? பேசுறது கேக்குதா? ரமேஷ் சார் கேக்குதா நான் பேசுறது?
நல்லாவே கேக்குது சார். நல்லாவே கிளியர் அண்ட் இனிமேல் நான் வாயை மூடி கொண்டிருக்கிறேன் ராஜேந்திரன் சார், கவலைப்படாதீர்கள்
சார். நீங்களா எங்களுக்குலாம் ரோல் மாடல் சார். நீங்க ரமேஷ் சார் எல்லாம் எங்களுக்கு வந்து லெஜெண்ட்ஸ்.
two types of role model. One is positive role model, இப்படி இருக்கணும் இவரை போலன்னுட்டு. இன்னொன்னு நெகட்டிவ் ரோல் மாடல், இவரை மாதிரி இருக்கவே கூடாது.
உங்களுக்கு தன்னடக்க அதிகம் சார்.
ஒன்ஸ் இன் வே பெரிய காரியம் சொல்றது ஈஸி சார். நீங்க வாரம் செய்யறீங்க. ஆல்மோஸ்ட் எவ்ரி டே ஆர் டூயிங் சார். ராஜேந்திரன் சார், கிரேட் திங்.
ஏதோ மக்கள் பெனிஃபிட் ஆனா சரிங்க சார், அவ்வளவுதான்.
thousands of people are getting benefited sir. Definitely sir. இது எங்க யாருக்கு இந்த வாய்ப்பு கிடைக்கும்? உட்கார்ந்த இடத்துல knowledgeable people are coming and talking. It's a great thing. ஏன்னா இந்த காலத்துல ஒருத்தர் பேசிக்கிறதே கிடையாது, எல்லாம் செல்போன்ல தான் பேசிக்கிறாங்க. At least here you can see face to face and talk.
பரவாயில்லைங்க சார். எப்படினாலும் ஒரு 600, 650, 700 people தேர் மினிமம் அட்டெண்ட் பண்றாங்க.
ஆமா, நானும் கிராஸ் செக்ஷன் ஆஃப் தி பேஜஸ் கேக்குறேன். பட் many of them at least 5 to 6 times are listening or the YouTubeல ரெக்கார்ட் பண்றத பாக்குறாங்க சார்.
ஆமா சார்.
ஏன்னா இது ஃபுல் இது அப்படியே போகுமா சார்? எடிட்டட் வெர்ஷனா சார் இது?
சார் இது அப்படியே இது பண்ணிட்டு யூடியூப்ல அப்லோட் பண்ணிடுறோம். சோ அதனால யூடியூப்ல அப்படியே இருக்குங்க சார்.
Such a stupendous effort should not go waste.
ஆமா சார், that's my idea also. சார் எவ்வளோ இது பண்றது, you should reach larger number of people.
No matter, each one is discussing in a very extensive way, and then some guests this thing, faculty are coming, so it will help all the postgraduates.
ஆமா சார், especially smaller medical colleges where they don't have super specialistலாம் இல்லாதவங்களுக்குலாம் இந்த மாதிரி interaction with specialist people who are working.
நான் நிறைய கத்துக்கிறேன்னா அவங்க எவ்வளவு கத்துப்பாங்க பாருங்க.
கற்றது கைமண் அளவு தானே சார் நமக்குலாம்.
Everything is subspecialty specialists are coming, so that go to a higher level of discussion. So
ஸ்ரீரங்கத்துக்கு என்னைக்கு சார் போனீங்க? சீனிவாசன் சார் அன்மியூட் பண்ணிட்டு.
அஸ்வத் காட்சி அளிக்கிறாரே.
ஆமா, ஒரு
அஸ்வத் தர்ஷன், அஸ்வத்துடைய தர்ஷன் கிடைக்கிறது அபூர்வமா இருக்குது. வெரி குட்.
அவர் தலைவர் மாடரேட்டர்ல இன்னைக்கு
ஸ்ரீரங்கத்துல ரங்கநாதரை பார்த்ததை விட அஸ்வத்தை பாக்குறச்சே இன்னும் மகிழ்ச்சியா இருக்கிறது.
சார் அன்மியூட் பண்ண சொல்லுங்க அவரை.
அன்மியூட்.
குட் ஈவினிங். குட் ஈவினிங்
அஸ்வத் பாஸ். இப்பதான் நான் வந்து என்ன பொருட்டி எடுத்தாரு.
யாரு? ஸ்ரீனிவாசன் சாரா?
நீங்க வந்துட்டீங்கன்னா எஸ்கேப்.
என்னப்பா நான் போட்டு நான் சொல்றது எவ்வளவு சின்சியரா சொல்றேன், அவெல்லாம் விளையாட்டா எடுத்துக்கிறாங்க. என்ன பண்ணுறது? நான் சிரிச்சுக்கிட்டே பேசுனா தமாஷ் பண்ணதான் நினைக்கிறாங்க.
இல்ல நீங்க சொல்றதெல்லாம் நாங்க டிசர்விங்கான ஒரு சந்தேகம் எங்களுக்குள்ள, அவ்வளவுதான், வேற ஒண்ணும் இல்ல.
Never doubt my sincerity, sir.
We don't doubt your sincerity, sir, but we are doubting our values.
Introspection is always good for health, for brain health. தானே சொன்னீங்க, கட்டுறது கை மண் அளவு கல்லாத உலக அளவுன்னு. அதனால எப்பவுமே ஒரு ஃபீலிங் இருக்கணும், நம்ம இன்னும் கத்துக்க வேண்டியது இருக்குன்னு. அஷத் அதை ஃபாலோ பண்றாரு. அதனாலதான் ஒரு அறிவு அதிகமா இருக்குது அவர்கிட்ட.
Sir, I'm Dr. Rajendra. Sir, did you get a link, sir? Right, sir. Okay, sir. Okay.
If you don't know anything, it's okay, sir. But if you don't have the curiosity to learn, it's not okay.
Aswath boss, Dr. Aswath. Hello.
Seth has gone incognito. Students will come.
Good evening, Winsley, sir.
Good evening, sir.
Winsley, good evening.
Good evening, Dr. Ashwath. How are you?
சுனில் ஸ்ரீனிவாசன் மாதிரி கொஞ்சம் தெரியுறீங்க வின்ஸ்லி.
அறிவு எல்லாருக்கும் உண்டான கலர்ஸ் தருது.
Dr. Winsley, welcome.
Thank you, sir. Thank you, Dr. Rajendra.
அல்ல என்ன மஃப்டில இருக்கீங்க இன்னும் வீட்டுக்கு போலியா?
என்ன போகலைங்க, கொஞ்சம் லேட் ஆச்சு. போயிடலாம், பாதி வெளியில ப்ராப்ளம் ஆயிருக்குல்ல.
சரி சரி.
ஆரம்பிச்சிட்டோம்னா ஆரம்பிச்சுட்டு அப்படியே கேட்டுட்டே போயிருவேன்.
Dr. Winsley, Dr. Ramesh.
டாக்டர் சீனிவாசன் வந்திருக்காரு சார், கோச்சுக்காரு. எங்க வந்திருக்கேன் நீ காணா அப்படிம்பாரு.
As usual, panelists, judges எல்லாம் முதல்ல வந்துருவாங்க. கடைசியில ஸ்டூடெண்ட்ஸ் பேண்ட் வேகன் லேட்டா லாஸ்ட் லேட் லத்தீஃபா வந்து ஜாயின் பண்ணணும்னு நினைக்கிறேன்.
It's an unwritten law, sir. Audience come late.
Dr. Serene. Dr. Serene. Unmute, ma. Unmute.
Hello, sir. I'm Dr. Janaranjani, sir. I'm trying to log in, sir. I couldn't log in, sir. Just 2 minutes, sir.
Yeah, you can.
Yes, sir. Join, sir.
Check it.
Good evening, sir.
Gopal. good evening.
கோபாலு வந்திருக்காரு. ரொம்ப சந்தோஷமா இருக்குது சார்.
Sir, good evening, sir.
டாக்டர் அஸ்வத் இவர் பாத்தீங்கன்னா கோபால் இப்படியே இருப்பாருங்க. நான் அடுத்த வாரம் வரைக்கும் அப்படியே இதே கொஸ்டின் இருப்பாரு.
ராஜண்ணா.
ஜனரஞ்சனி அன்மியூட்டுங்க அண்ட் ஷேர் ஸ்லைட் ஷேர் பண்ணி செக் பண்ணிடுங்க.
எப்படி இருக்கீங்க?
Very fine.
Ramesh sir, good evening.
Good evening, sir. Subramanian, sir.
Sir, I must confess, this is my first time on this platform. So, I don't know how exactly this whole program
Whatever
goes.
you are doing is going to be this show.
Sir, myself, I will introduce chairperson as well as moderator, sir. And postgraduates, they are going to present the case, like exam presentation like that. So you can ask in between. You are going to conduct the program, and Dr. Aswath as well as Dr. Balaji, they will join with you. And like exam pattern, sir, you can ask questions, and if they are not answering, you can answer, sir. That's I think. And 3 PGs already. 1 PG they are going to present, and the 2 PGs they will be there. You can ask question towards other PG also.
Okay.
Like same exam, sir. Like some
Okay.
exam.
So I guess, anybody can ask a question in between, no?
Yeah. You wherever you want, you can stop. You can ask, sir.
Okay, sir.
And there are 5 judges are there: Dr. Srinivasan, Dr. Ramesh, Dr. Janani, and Dr. Rama Chandramohan, and Dr. P. Ramchandran, sir. They will watch the presentation, and they will award mark also for postgraduates. At the end of the presentation, they will give their comments also, sir.
Okay.
Good evening, Ramesh, sir.
Good evening, sir. Srinivasan, sir. Good evening, all.
Good evening, Ramesh.
Good evening, President Ramesh, Professor.
Sir, good evening, sir. Very good evening, sir.
Dr. Ramesh, welcome.
வணக்கம் பாஸ், நல்லா இருக்கீங்களா? வெல்கம். கொஞ்சம் லேட் ஆயிட்டேன்.
பாலாஜி மட்டும் we are waiting for Balaji.
பாலாஜி வெயிட் பண்றீங்களா?
பாலாஜி.
ஓகே.
ஜனரஞ்சனி ஷேர் பண்ணி பாத்தீங்களா? Janaranjani, share your slide and check it. Okay, right.
Good evening, Professor Winsley Rose, sir. Good evening, Gopal.
Good evening, Dr. Ramesh.
Good evening, Ramesh, sir. Good evening,
Sir,
Rama.
Good evening, all of you.
Madam Balaji, join பண்ணிட்டீங்களா? உங்களுக்கு தான் வெயிட் பண்ணிட்டு இருக்காங்க. Good evening, Ashwat, sir. Good evening.
Good evening. Babu, sir. Good
evening,
Good
Srinivasan,
evening,
sir.
Dr. Balaji. Good evening, Dr. Rama, Madam.
Good
Balaji,
evening,
welcome.
sir. Good evening to all of you.
Other judges.
Good evening, ma'am.
Good evening, all.
Janaranjani, full screen போங்கம்மா.
Yes, sir.
Good evening to all the presenting
Sir, I've
students.
shared
and
my
visitors.
screen, sir.
Yeah, you can go for
Sharing.
free share, ma.
I've shared some my screen presentation.
We can see your presentation. Make it full screen, he's saying.
Okay, sir. Okay, ma'am. Sorry.
ఇక్కడ அந்த கீழ 68% இருக்குல அது பாட்டம்ல அது கிளிக் பண்ணுங்க அந்த இடத்துல. Yeah, you can go for it.
Good evening, all.
Good evening, all. Dr. Balaji, good evening.
Good evening.
Thank you, sir.
Balaji.
My right side bottom la பாரு full screen mode இருக்குல அதை கிளிக் பண்ணுங்க அத.
Yes, sir.
கீழ பாருங்க ரைட் சைடு பாட்டம் கீழ வாங்க.
Yes, ma'am. Yes, sir.
கீழ வாங்க அந்த 68% அதுக்கு நியர்பை.
Yes.
அதான் சேம் யா கிளிக் பண்ணுங்க அத.
Yes, sir.
அப்படியே வேணா காமிச்சிடுங்க. இட்ஸ் ஓகே.
இல்ல ஸ்லைட் ஷோ போட்டா வரலையா?
ஸ்லைட் ஷோ அந்த இதுல கிளிக் பண்ணா வரணுமே. அப்படி வரலன்னா இட்ஸ் ஓகே. இட்ஸ் விசிபிள்.
நீங்க 100% போனா இது அதிகமா இருக்குல்ல?
இல்ல இது 100% போட்டா அது ஃபுல்லா தான் தெரியும்.
இது குறையுமா? அது ஒரு 68 இருக்கட்டும்.
ஃபுல் ஸ்கிரீன் வராது.
68 குறைஞ்சுங்க. 68 பண்ணுங்க. அண்ட் இல்ல ஸ்லைட் ஷோ இது போடுங்க. ஸ்லைட் ஷோ போடுங்க.
ஸ்லைட் ஷோ போட்டா வந்துரும்.
ஸ்லைட் ஷோ இல்லனா F5 போடுங்கம்மா.
ஸ்லைட் ஷோ ட்ரை பண்ணுங்கம்மா, வந்துரும். In case it's not there, even this is visible.
F5 தட்டினா கூட வந்துரும்.
Now, sir?
ஓகே, நீங்க அது ஸ்லைட் ஷோ போட்டீங்கன்னா கம்ப்ளீட்டா வந்துரும். நீங்க அந்த சைடுல அதுக்கு தெரியும். சைடுல
Yes, sir.
ரைட் பாட்டம்ல ஒரு இது ஸ்கிரீன் படம் போட்டுருக்கோம். அதை டச் பண்ணா போதும்.
Yes, sir. அதான் போட்டுருக்கு சார்.
ஓகே.
சரி பரவாயில்ல, அப்படியே ஆரம்பிங்க.
இல்ல உங்களுக்கு இப்போ ஒண்ணுமே வரலையே, கம்ப்ளீட்டா ஸ்டாப் ஆயிடுச்சு.
Now, sir?
Blackout.
Now, sir?
Sometimes when you move
Black screen.
continue like this, ma, maybe you're having a problem going to slideshow.
ஓகே, அப்படியே பரவாயில்ல விடுங்கம்மா. ரைட். We will start the meeting. Okay.
Sir, now can you see my screen, sir? My slide,
Yeah.
sir?
We can see it, ma. We can
Yes,
see.
sir.
Just continue.
Good evening to everybody. On behalf of IAP TNC, I welcome one and all for this postgraduate teaching program. And I first will start with the pediatrician prayer by Dr. Gopal Subramaniam, our president.
Good evening, one and all. Welcome all on behalf of IAP to this DIP program on postgraduate clinics in pediatrics. குழந்தை மருத்துவ நெருங்குதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும், நோயின் துன்பத்திற்கும் திறன் நமக்கு வழங்கப்பட்டது. எப்படிப்பட்ட சிறப்பு எல்லா குழந்தைகளுக்கும் அவர்கள் குடும்பத்தினருக்கும் அவர்களின் சமுதாயத்தை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாத காரணத்தை ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் பொறுத்தலும் எங்களுக்கு வழங்குக. உங்களது வாழ்க்கை அருளையும் கருணையும் எல்லா சூழல்களும் நேரங்களிலும் அனைத்து மக்களையும் கொடுத்து அருளுங்கள்.
Thank you, Dr. Gopal Subramaniam. And now I request our dynamic president, Dr. Ramesh Babu, to deliver presidential address.
Good evening all. Respected Secretary Dr. Rajendran sir, respected Treasurer Dr. Gopal, respected past President 2021 Dr. Ismail and President-elect Dr. Suresh Balan, and respected judges for today's event, Dr. Rema Madam, Dr. Srinivasan sir, Dr. Ramesh sir, Dr. PRC sir, and Dr. Janani Madam, and the respected chairperson for today's program of PG clinics in pediatrics, fever with Hepatosplenomegaly, Professor Winsley Rose from Christian Medical College, Vellore, and the respected moderators, Dr. Ashwat sir from KMCH, Coimbatore, and Dr. J. Balaji sir from Dharmaburi Medical College Hospital, and my dear postgraduates, Janaranjani, Shahana, and Serene. I hope you will do good in today's program and keep up the spirits of Government Dharmaburi Medical College Hospital, Dharmaburi. I should appreciate our dynamic secretary, Dr. Rajendran, for his untiring efforts in conducting this PG clinics as well as UG clinics on alternate weeks. successfully for the past 3 years. I think if the postgraduates attend these programs for the entire 3-year period, I think they will be mastered in pediatrics, because a wide variety of case presentation with the faculties spread all over the state as well as from all over the country. They will be enriched of almost all the points and the knowledge, both as well as exam oriented points as well as in practicing scenario. This short note, I appreciate the efforts of Dr. Rajendran once again, and I hand over it to Dr. Rajendran to carry out the proceedings further. All the best for the postgraduates. Thank you.
Thank you, Dr. Ramesh Babu, and respected our President, Dynamic President, Dr. Ramesh Babu, and President, Dr. Gopal Subramaniam, and Vice President, Dr. Annamalai Vijayaraghavan, and President-elect, Dr. Suresh Balan, President 2021, Dr. Ismail, and AAA, Dr. Thirumurugan Sarane, and Editor, Dr. Dashani, and all other central as well as state DB members, and welcome and all. And I welcome our judges, Dr. Janan Sekhar from Chennai, Dr. P. Ramachandran sir from Chennai, and Dr. S. Ramesh from Chidambaram, Dr. Ramachandran Mohan from ICH Stanley, and Dr. Srinivasan sir from Pondicherry. And on behalf of IAP TNSC, I welcome all the judges. And today I welcome our chairperson, Dr. Winsley Rose, is a known infectious disease specialist and in pediatric person. He's a renowned speaker also in various infectious disease conference. He is currently a professor of pediatrics, Christian Medical College, Vellore. I welcome Dr. Winsley Rose. I welcome today's moderators, Dr. Aswath Paraisamy, my colleague and as well as my good friend. He's currently a senior consultant in pediatric and as well as neonatology, Huawei Medical Center and Hospital, Coimbatore. I welcome Dr. Aswath. I welcome Dr. J. Balaji. He's currently Associate Professor of Pediatrics and as well as is not a known person for intensive care specialist also. He's currently working as in Dharmaburi Medical Government, Dharmaburi Medical College. I welcome Dr. Balaji. I welcome all the learners and postgraduates, Dr. Janani, Janaranjani, and Dr. Sagana, Dr. Sarin from Government Dharmaburi Medical College. And once again, I welcome one and all for this wonderful postgraduate teaching program. And now it's over to Dr. Winsley Rose, and we can start to presenting case. Sir Winsley, sir, please.
Thank you, Dr. Rajendran, for the kind introduction. So I guess we will start with, so one of you is going to present, no? So is it Jana Ranjani who is going to present?
Yes, sir.
Okay. Jana Ranjani, can you just try once more? Just hit F5.
I've clicked, sir.
Okay. So nothing's happened. So I thought it's okay. We will continue like this. Anyway, it's not going into the presentation mode, so it's okay. We will continue like this. So you can start your presentation, Jana Ranjani, and then I request the other moderators in the session to, ask questions as and when they deem appropriate. And I guess so that do the judges also ask questions if you want to?
So then finally, the end of the session, they will come and send.
Okay, so it will be only the Dr. Ashwath and Dr. Balaji and Dr. Ramesh who will be asking questions, and including me.
Okay. Please
okay.
proceed.
Yeah.
The
okay,
judges
Dr.
will send questions in the chat box, sir.
Okay.
Judges will ask a few questions in the chat box, which the moderator or the chairperson can post to the students, sir.
Sure. Okay.
Yeah, you can start presenting. Yeah.
Yeah, Dr. Jana Ranjani, you can start.
Good evening, one and all. I would like to thank the IAP PG Clinics, IAP office bearers for giving me this opportunity. I would like to thank the IAP President, Secretary, all the assistant professors here for giving me this opportunity. And I'd also like to apologize for the technical lag, initial technical lag. I'll start with my presentation. Master Sashwin, 2-year-old male child from Matlampatti, whose informant is mother and reliability is good, was brought with the chief chief complaints of fever for the past 8 days, vomiting for the past 2 days. History of presenting illness. The child was apparently normal 8 days back and was being brought with the chief complaints of fever for the past 8 days. Insidious in onset, intermittent nature, high grade, not associated with any chills and rigors, relieved with antipyretics, no history of any diurnal variation, and the child was active during the interfebrile period. History of associated vomiting present at 2 days at the onset of fever. 3 to 4 episode. Vomitus contains undigested food particles, non-bilious, non-bile stain, not blood stain, non-projectile, and no further episodes of vomiting. No history of associated abdominal pain, loose stools, abdominal distension. No history of cough, cold, or breathing difficulty. No history of cry during micturition, increased frequency or dribbling of urine. No history of reduced urine output. No history of facial puffiness or swelling of limbs. No history of yellow discoloration of the eyes or urine. No history of headache, seizures, lethargy, or altered sensorium. No history of ear discharge. No history of skin rashes. No history of joint pain. No history of bleeding manifestations like hematemesis, hematuria, melena, gum bleeds, or skin bruises. No history of redness of eyes or discharge. No history of recent travel. No history of loss of appetite. No history of significant weight loss. No history of night sweats or bone pain. Past history. Not a known case of congenital heart disease, bronchial asthma, or seizures in the past. No history of previous hospitalization for similar illness in the past. Treatment history. The child was initially treated in a private hospital for the above complaints and was treated with oral medications for 3 days. As the child had recurrent fever, child was brought to GDNCH on day 8 of illness. Antenatal history. Third born 2 years, birth spacing 4 years, spontaneous conception.
Janaranjani,
Yes, sir. Yes, sir.
can we take a brief stop here and review some critical points in the history, ma?
Yes, sir.
Can you tell the audience and the judges why the address is important? You said this child comes from a particular place. So would you be able to tell us why that address is important? The very first, like, yeah.
Sir, certain infectious diseases are endemic in certain areas. So in order to know those diseases are, if the patient comes from that region, the address is important, sir.
Very good. Can you tell me some parts of Tamil Nadu where you will consider this pattern?
Sir, malaria is common in coastal regions, Hokkainakal, Kanyakumari regions, sir. Scrub typhus is common here, sir, in endemic region in forest terrains.
Okay. In scrub terrains, not forest terrains, in scrub jungles. Scrub jungles. Yeah. Fine. What else? Is there some part of Tamil Nadu where you will get a history of travel to that place to consider malaria as one of the etiological considerations? Do you know parts of Tamil Nadu where malaria is more common? Chennai?
Coastal
Ramnad
region.
district.
Chennai
and coastal region, especially Ramnad district. Yeah. So it's very important to know the history of the child, recent travels, and also a place. What else is important, ma? Do certain parts of Tamil Nadu have rains during certain times, right? So does the season in which the child present also make you consider the alternate differentials?
Sir, if there is recent rains, dengue can be considered, sir.
What else, ma? Very good. Your answer is correct. Can Dr. Shahana answer this question?
Sir, good evening, sir. Dengue is more common during June to October season, sir, during rainy season. And in case of rainy season and near rice field leptospirosis, we can suspect, sir.
Very good.
Then
your voice is breaking.
Sir, plain areas and urbanization, scrub is becoming more endemic because of people living in plain areas and recent urbanizations.
So the point I was trying to say was because the topic is very clearly said fever with hepatosplenomegaly. Whenever you have a child with a fever hepatosplenomegaly, the time of the year at which the child presents to you will also have a big say. As you very rightly pointed out, they are called the monsoon maladies, right? So the Aedes aegypti tends to proliferate during the rainy seasons in fresh, stagnant water. So given our urban misplanning, we have lots of pools of undrained water, which is a very favorite breeding ground for Aedes. So dengue definitely is a very good tropical disease, which you consider during monsoon time. Also leptospirosis. And the area of importance of residence is important because of travel. Is there anything else you would like to ask Dr. Sherin Farhana? She has given a very exhaustive no history of. There is also a mention of a history of significant weight loss. The child's history is only 7 days. In 7 days, would you expect significant weight loss with only 2 episodes of 2 days of vomiting? Ma? Is that a valid history?
Sir, any acute presentation of a chronic disease?
Yeah, but she said the child is previously well in the very first slide. Would you consider weight loss as a significant finding for a child with a 7 days illness? Okay. So broadly, when a child comes with 7 days of fever, what are the things that you consider, Ma? Where do you target your history taking?
What are the associated symptoms, sir?
Correct. So in this child, is there something you would like to ask for extra in addition to what she's already said? She has given a very detailed history of relevant negative histories. There are some things which she has missed out. Would you be able to help your colleague? If you are in General Engineer's position, you are the person who is in first contact with
history of lethargy, sir.
History of lethargy? That's a very non-specific complaint, no, ma?
Yes,
I mean, even a short direct say you and I have a viral fever, they'll feel lethargy. Anything else? Because it's a tropical country, 7 days history of fever, history of recent travel, she's already mentioned. Yeah, she's already mentioned that. Can we go to the next slide, ma? Yeah, there's the third point. No history of recent travel. Dr. Sherin. Dr. Sherin, are you with me?
Yes, sir.
Okay. So when a child's fever has lasted for more than 7 days, what are the differential diagnoses that you're not considering anymore? What are the things that immediately go into the back burner, so to say? Are you getting my question? My question is, if the child's fever is already lasted for 7 days, what are the differentials that you will not consider serious?
Simple viral fever, sir.
Very good.
Yes,
Viral
sir.
fever. What about things like tonsillitis, acute otitis media, acute
Simple
diarrheal
viral
disease?
fever.
Yes. So those are less likely. Is there some? Okay. Is there something on the skin that you'd like to ask from? I don't think I got that. On the skin, is there something?
Impetigo lesions.
History of rash. Yeah, history of rash is something which is very, very useful for us because the pattern of rash and the involvement of the organs, where the rash came first, what the duration of the rash, fever the rash first appeared in, they will be very, very useful to make a diagnosis. Correct? So she has written
Yes,
there, no history of skin rashes. Correct. General Anjani, can you tell me if this child had a rash which came only at the time of fever and disappeared after the fever went away, would that give you some diagnostic clue? Can you tell me some skin rashes that are of diagnostic importance to you as a clinician, which you can elicit from history? You have not gone to physical examination.
Fever with rash.
Measles, sir.
Very good, ma'am. So what would the typical rash of measles be like? Can you describe?
Once the fever subsides, the rash appears
That's not quite true. The fever is preceding the rash by at least 4 to 5 days. In fact, the fever peaks when the rash starts. The rash typically starts in the retroauricular area. It starts on the forehead face and then goes from top to bottom. By the time it has reached the feet, it started to fade away or become brownish discoloration in the face. That is a typical pattern of the skin rash. So measles. Anything else, ma? Suppose a child came with fever and intense body pain along with a rash over the malar area during monsoon. Very irritable child, fever with rash, typically over the malar area where you see the butterfly rash of SLE. If a child comes to, what will you think of?
Connective tissue disorder.
Any infectious disease, ma? Fever, irritability, intense muscle pain, child resents being handled, monsoon time, child has got rash over the cheeks, child has got a hepatomegaly.
Monsoon region, monsoon time.
Anything else which comes through Aedes aegypti other than dengue, ma?
Yellow.
Come on. Yellow fever is not an Indian disease. Chikungunya. Hello.
Audible?
I'm losing their audio repeatedly.
Hello?
Hello, sir.
Audible, pa? What happened to your audio, pa? Hello?
Looks like they've got disconnected.
Yes.
Very fit. என்னாச்சுப்பா?
She can join through her phone and ask one of her colleagues to move the slides. That's another option.
Hello, sir.
Yes, Jalaranjani.
Yes, sir.
Okay, so the disease that we were talking about, I think you need to
Share
go to
the
screen share, ma?
screen, pa?
Screen share, we are seeing your.
Sharing, sir.
Okay, so you're taking the questions, ma?
No, sir. Sorry, sir. Can you please repeat the question, sir?
No, my question was, a child who comes with fever with rash for 7 days duration, if the child
Yes, sir.
had intense irritability, rash over the malar area, is there some other infectious disease you will consider during the time of the monsoon? Is the question. Fever, rash, intense irritability, and the rash distribution is over the malar area of the face. Is there a particular infectious disease that you'll consider? The clue I gave you was it's during the monsoon. I further gave you a clue that it's an infectious disease which is also transmitted by Aedes aegypti.
This is phylloxera myalgia.
Very good.
Yes.
Correct. So chikungunya is another fever.
Sir.
Correct. Your answer is right. I've
Yes.
already said. Yes. What about a rash which comes at the height of fever and disappears when the fever goes away? Fever of 7 days. Rash which comes only at the height of fever and then the rash goes away. The child has a bit of muscle pain and also has hepatosplenomegaly. What fever would you consider in this situation?
Typhoid, sir.
Typhoid rash typically comes at the end of the 7 days, no?
7 days.
We are talking about a rash which comes and goes. The rash comes when the fever comes. When the fever goes down, the rash also goes down. And the fever comes as high-grade fever. Twice, 2 times or 3 times in a day, the fever touches 103, 104. Between that, the child is active and playing. But when the fever comes, the entire body becomes covered like a salmon pink rash. Is there something you will consider?
Scarlet fever.
Scarlet fever rash is fixed, ma. It won't come and go.
Okay.
Yes. You'll get a sandpaper appearance to the skin. Skin will be very rough, and the child would have had a history of a sore throat, and the child would have an asymptomatic rash, which is fixed. The entire skin will be like a truly Takali fever. That is a true tomato fever. Correct? The skin looks like it is being smeared with tomato sauce. The correct answer, anybody, any of your colleagues, would Sahana or
Hello, sir.
sorry, what was the answer, ma?
No, sir. No ideas.
I asked whether your colleagues would like to answer the question. Would Sahana or Shireen try to help you? No, they are not there with you. Okay, the answer I wanted was systemic onset JA. In systemic onset JA, you get a rash which comes. Sochia. Rash comes and goes with the
Yes, sir.
fever.
Sodia. Evanescent rash. Yes, sir.
Correct. So the rash comes at the height of fever, and the fever goes away, the rash goes away. Many of these
Yes,
people
sir.
will have hepatosplenomegaly, and they may also have
Yes, sir.
very non-specific joint complaints at the outset.
Yes.
Okay. Right.
Yes,
So
sir.
fever with rash should give you some diagnostic consideration based on the distribution of the rash, the pattern of the rash, the rash, and the fever on the day. Okay. Correct?
Yes, sir.
Fine. Dr. Balaji, is there something you'd like to ask them? Professor Rose?
Look, generally, you mentioned, in fact, your first thing that you mentioned about when Dr. Ashwath asked was measles. You said the fever goes away and then the rash appears. And Dr. Ashwath told you that's not the case with measles. It's actually at the height of fever. Do you know a disease which actually where the fever goes away and then the rash appears? It's actually a very common childhood illness. And this 1 to 2 years is probably the usual age group for this kind of children. It may be associated
Hand
with
and foot mouth disease, sir. Hand and foot mouth disease. Fever appears, then the lesions appear.
I mean, for the hand, foot, and mouth disease, I mean, so the rash is only in the palms and soles, and maybe in the throats, maybe in the extensor aspects. This is a generalized kind of a rash. It's a very common childhood illness. It can be associated with febrile seizure also. So if I can give you a clue, it's caused by a herpes virus.
His name is also the clue. What is doctor? Who's asking your question? What's his name? Who's asking you the question, Jananjani?
Yeah, that's another clue.
Dr. Winsley, what?
Yes, sir.
Dr. Winsley, what? Yeah, and the next name. He's Dr. Winsley Rose.
Rose, okay.
So that is a
rose spots. Rose spots.
Okay, okay. So it's roseola infantum or exanthum subitum, no, which is caused by
Great
HHV6.
clue you are giving us, Shrath. Very good.
So HHV6. Anyway, now that we are at rose spots, where do you get rose spots anyway?
Enteric fever, sir.
Okay. So where do you find them?
Over the chest and the trunk, sir.
Okay. So Dr. Balaji, you want to ask anything?
Actually, in this COVID scenario, a child came with fever and rash for the begin ears and cheek. So anything you want to add diagnosis in today's scenario? Dhananjani?
Yes, sir.
I'm audible?
Yes, sir. Yes, sir. You're audible, sir.
In post-COVID scenario, today's post-COVID scenario,
Mrs.
a child come with acute febrile illness. Yes. So, Mrs. due to?
Mrs. sir, fever, rash with conjunctival suffusions.
Okay. Correct. Good.
Conjunctival redness.
So when you said past history of no this, post history of no that, you also tried to include whether there was a family outbreak of COVID, whether this child was diagnosed to have COVID. That's what Dr. Balaji is trying to tell you. See,
Yes, sir.
once we have committed yourself to infectious disease, your mind keeps going only in the infectious disease pathway. But whenever you have had fever for more than 7 days, you should cast the net a bit wider. You have to think of infection, you have to think of inflammatory disorders as well, and you will have to think of infiltrative disorders and immune disorders. Remember all the 4 I's, okay? Infection in our country will always be number 1, but you'll also consider immune disorders, inflammatory disorders, and infiltrative disorders. Clear?
Yes. Yes, sir.
Okay. So can you tell us some inflammatory disorders that you will consider in the differential diagnosis here? Fever of 7 days duration. What are the inflammatory conditions that are in the differentials?
So Sogia, sir.
Very good.
Other malignancies.
No. We are talking about inflammatory conditions. Why do you bring infiltrate?
Inflammatory.
Sir gave you a clue, no? Dr. Balaji asked you in this current scenario. Missy, correct.
Missy, sir.
Very
Missy,
good. What is the
Sogia,
disease that
Missy.
is? What is a disease that is very likely to be mistaken for Missy before we
Kawasaki,
knew?
sir.
Very good. Kawasaki. What else? Sogia, Kawasaki, Missy.
Missy.
Can you tell me what is dress syndrome? Dress, does it mean anything apart from what you are wearing and what you like to purchase? Is there any other dress you like to know?
Is a question, sir?
What does dress mean to you? Dress.
Dress syndrome.
Yeah, what is dress syndrome? Tell me.
No, sir.
You said that child was treated with some medicines, no?
Yes, sir. Antipyretics.
Okay.
Okay, you don't need to get stressed. This is absolutely fine. It's only a learning experience. We didn't know it at your age either. It's our teachers who taught us all these things. So drug rash, eosinophilia, and systemic symptoms. So this is a condition which you will have to consider, especially because of the widespread abuse of drugs, antibiotics, drug rash, eosinophilia, systemic symptoms. So children may come with fever, hepatosplenomegaly, and they will come with a rash. So that's another inflammatory condition. It's a close mimic of Stephen Johnson syndrome and toxic hepatosplenomegaly. So that concludes your inflammatory differential diagnosis for a pyrexia, which is no longer a short pyrexia. Okay?
Okay.
Fine. What are the other conditions we said? We said infection, then you'll have to take inflammatory disorder.
Inflammation.
Okay. So what history would you have asked for this patient if you wanted to get these histories?
So skin rashes.
Very good.
Joint pain.
Very good. More than joint pain, joint swelling.
Joint
Because
swelling.
arthralgia is different, arthritis is different. So you want to ask for history of joint swelling, you have to ask for joint pain and inability to bear weight and move joints. Very good. What is
Prolonged history, sir.
No, this is a acute history. You are presenting Ashwant with a 7-day history and you have committed that he's been previously well checked. So I'm talking about in this check. Oh God.
Breathing difficulties if serositis involved.
Okay. So a serositis technically means inflammation of the serosal cavities. So you may have a bit of pericarditis, a bit of pleural effusion, a bit of ascites. But please understand that a infectious serositis will never accumulate so much of volume that will cause respiratory distress. So I would not accept that as a valid answer. If you said pleuritic pain, that is a different thing. Precordial pain, pleuritic pain is a feature of serositis, not respiratory distress. The volume of the serous diffusion will never reach such a significant amount. Okay. So you said joint pain. Again rash.
Yes,
again
sir.
joint swelling.
Yes, sir.
What else?
Joint
History
swelling.
of contact with COVID or a past history of COVID. Is there some point
COVID.
which will
Yes,
help
sir.
you to diagnose Kawasaki disease? An astute mother might pick it up, or an astute clinician like you should ask.
Strawberry tongue lesions over the oral mucosa, tongue
Correct.
coating.
So the baby may be having bleeding gums, the baby may be having sore tongue, lips, and others. Is there something on the left hand that the astute mother or clinician can ask for something over the
BCG.
left. Very good. What happens to the BCG scar during a course?
Erythema.
The BCG scar may actually ulcerate. You may get a small serous sanguinous or even a purulent discharge at the height of fever in Kawasaki. So if you get that history or the mother notices that finding, that's a very, very useful point to remember. So first, whatever history you've taken and presented Dr. Janaranjani is very partial towards infectious diseases. It is rightly so. In our country, I think that is number one. There is no doubt about it. But when the fever has lasted for more than 7 days, you also have to consider inflammatory conditions. Therefore, Kawasaki, a history of irritability, rash, history of sore mouth, sore tongue, all these points which you elicited, definitely they are also valid. What else? What about infiltrative disorders? What are the points that will tell you about an infiltrative disorder, ma?
Bone pain. Bone pain, sir.
Okay, bone pain. What else?
Night sweats.
Your voice is breaking, Janaranjani.
Bone pain, night sweats, sir.
Janaranjani, please mute your video, doctor. Okay, please mute your video. I think you can do it. And if you're not possible to share slide, please send to DIP. We will share it.
Sir, I've shared my slides, sir.
Yeah.
Yeah, congratulations. We are back on track.
Yeah, mute your video. That's enough. Right.
Okay, sir.
Okay, so what are the points in the history that will make you consider an infiltrative disorder? We've said infection, we've gone to inflammation. Now, what are the points in the history, Dr. Sahana, that will make you suspect an infiltrative disorder? Dr. Sahana? Dr. Sherin?
Hello, sir.
Yeah, Dr. Sahana.
So,
We have
Sharon mute,
considered
sir.
what history would like to point towards infection. What are the histories that you will suggest an inflammatory disease? Now we are on to the third category, infiltrative disorders. What are the points in the history that is present will guide you towards an infiltrative etiology as a cause of prolonged pyrexia? That's my question.
Sir, I can't get you, sir. Sir, sorry, sir.
The question was, what are the points in the history you would ask for if you're considering infiltration as a cause for prolonged pyrexia? Suppose the child is having hematoreticular malignancy, the child may
Bleeding
present with fever,
manifestation, sir.
hepatosplenomegaly. What are the additional points that will guide you towards an infiltrative etiology rather than an infective or inflammatory etiology?
Sir, bleeding manifestation, sir.
Such as?
Bleeding gums.
Very good.
Fatigue.
What else? Very
Fatigue.
good. Yes. What else?
Sir,
Bone
night
pains.
sweats. Night
Bone
sweats.
pains.
Bone pain.
Bone pains,
These
inability
symptoms.
to bear weight, persistent irritability, rash, spontaneous bruising, bleeding gums, epistaxis, prolonged bleeding from IV puncture sites. Yes,
Yes, sir.
and recent onset pallor.
Yes, sir.
Recent onset pallor, night sweats,
Yes,
which
sir.
you said. All these would point towards the infiltrative
Infiltrative disorder.
etiology.
Yes, sir.
Okay, fine. You can proceed, Dr. Janaranjani. Are we ready to start? Resume?
ஷேர் பண்ணிட்டீங்களா? எனக்கு ஷேர் பண்ணிருக்கீங்களா? இல்லப்பா, உங்க இதுல ஷேர் பண்ண முடியுமா? Hello.
So
Dhananjani. Dhananjani.
Connection problem, I think.
Sir, hello, sir.
Are you able to share the screen, ma?
Sir, I've sent you the slides, sir. I've sent everyone the slides. Sir.
No, ma. Just wait. ஒரு நிமிஷம் ட்ரை பண்ணிடுறேன் சார்.
So, Janaranjani, are you there?
Yes, sir, I'm there, sir.
Yeah, okay. So while I think Dr. Balaji is fixing up your presentation,
Yes,
you
sir.
mentioned so many infections that we have thought about, no?
Yes, sir.
Can you just list out what are those infections that you would consider when somebody's come with 8 days of fever? I know you mentioned a lot of them. I'm just asking you to list them out.
Enteric fever, sir.
Okay, so that's the one thing which we didn't talk about.
Yes, sir.
Okay, so enteric fever.
Scrub typhus, sir.
Okay.
Malaria.
Yeah.
Sepsis.
Sepsis is it's a sort of a basket diagnosis term. You know, there is a specific, I mean, sepsis has a specific criteria to call something sepsis, no? So I would keep sepsis aside.
Leptospirosis, sir, if there was jaundice or any associated condition.
Yeah, leptospirosis, depending upon which region you come from, yeah.
Yes, sir. Infectious disease alone, sir?
Yeah, that's what I'm just asking you to list out the. You mentioned scrub typhus, malaria, typhoid, leptospirosis. Anything else?
Tuberculosis.
Janaranjani.
Yes, sir.
Janaranjani, when the professor is asking you a question, when you're answering question for infection, a smart PG immediately tries to classify. Correct? So you list out viral, then you go for bacterial, then you go for parasitic, then you go microbacterial, then you go rickettsia. You will miss nothing. Correct? So now can you reorganize your thoughts and answer the same question that Dr. Vinci asked you? Can you go organism wise?
Okay.
What are the bacteria that you'll consider? What are the viruses that will cause fever for more than 7 days? Parasites. If you go that way, you will not miss. Your differentials will be very, very streamlined.
Bacterial first, sir. Tuberculosis. Enteric fever.
Enteric fever, perfect.
Tuberculosis, I mean, usually you consider tuberculosis if the fever is more than 2 weeks, but yeah, that's okay. I mean, it will probably come lower down in your differential, yes.
Enteric fever, sir.
Okay, enteric fever.
Leptospirosis.
Very good. Yes, ma, what else? Suppose this child came from a rural area and is got a history of exposure to drinking unpasteurized milk. Is there some other differential?
Brucellosis.
Sir.
Very good. What else?
Malaria. Then
Have we done with bacteria?
Yes, sir.
The list of bacteria is quite extensive, but these are the top ones that you would consider. Can you go to the viruses? Which viruses produce fever for more than 7 days, ma? What are the viruses that you'll consider when a child's fever has lasted for more than a week?
VHF with cross infection, mixed infection.
Okay. What is Epstein-Barr virus infection?
Yes, sir. Infectious mononucleosis.
Yeah. So cytomegalovirus.
Cytomegalovirus.
Yes. Acute hepatitis B virus infection.
Yes, sir.
Acute
Yes.
HIV
Hepatitis
can
virus.
present as an acute febrile disease. So all
Yes,
these are the viruses that will present with a fever of more than 7 days duration.
Yes,
What are
sir.
the parasites that come with fever of 7 days duration now? Parasites?
Malaria.
Is it visible?
Cholera.
Is it visible?
Yes,
sir.
Dr. Balaji. Yeah.
Dr. Balaji?
It's a visible, Balaji. Yeah, you can proceed.
Yes, sir. Hello.
Janaranjan, you continue to answer the questions, ma.
Malaria, Kala-Azar, sir.
Malaria and Kala-Azar. Correct. So that makes your answer more comprehensive.
Yes, sir.
I would ask you to consider rickettsial infections also. I mean, not just scrub typhus, but other spotted fever rickettsioses also, which is actually not uncommon. And
Doctor, kindly slideshow, please. Yeah, thank you.
I hope everybody is visible. Everybody is able to see, sir.
Yes, sir. Perfect. Yes. Dr. Balaji, yes. Wonderful. Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.
Jayananjali, you can start presenting. Yeah.
Yes, sir.
So if a child came with fever of 7 days and redness of eyes, what were the differentials, ma? What were you considering?
Sir.
Very good. What else?
Kawasaki disease.
Yes. What else?
SLE.
SLE presents with red eyes, ma? Unless it has uveitis.
Redness, sir.
Sorry, ma?
Leptospirosis.
Leptospirosis.
Yeah, that's your answer is right. We have given
any inflammatory condition? Any inflammatory condition?
Kawasaki, sir.
Good.
Nearest, anything else? Close diagnosis? Anything else?
Misty,
sir. Missy, sir.
Okay.
What else? Measles. Measles itself causes quite a bit of conjunctivitis. Yeah. Coryza, red lips, measles, viral hemorrhagic fevers, Kawasaki, Missy, incomplete Kawasaki, leptospirosis. They all come with the same miserable looking children who have periorbital puffiness, lot of conjunctival suffusion, fever and rash with varying degrees of hepatosplenomegaly. Okay.
Yes, sir.
So I don't think in a 7-day history, Janaranjani, it would have been appropriate to write about history of significant weight loss in a previously well checked. Okay?
Yes, yes, sir.
Right.
Shall I go for next history, sir?
Yeah.
Then you can present the case, continue to present the case.
Past history, not a known case of CHD, bronchial asthma or seizure disorder. No history of previous hospitalization for similar illness.
So Janaranjani,
child was taken to a
just
private.
wait.
Yes,
Janaranjani, wait.
Excuse me, why was this particularly history taken for congenital heart disease, ma?
So
why have you written specifically that as the first point? I mean, why would there be a relevance to bronchial asthma seizure disorder in a child with fever of 7 days?
So it is generally to know the child's general condition, sir.
So why are you so partial towards congenital heart disease, bronchial asthma, and seizure disorder? So many conditions which affect children, no? Why have you singled out these three conditions? Asthma, congenital heart disease, and seizure is in any way related to the fever with hepatosplenomegaly that we are discussing?
So in congenital heart disease, the child can have respiratory tract infection, sir.
Okay. Would that come with hepatosplenomegaly?
No, sir. No,
so
sir.
Which condition in a congenital heart disease will come with fever and hepatosplenomegaly?
Infective endocarditis.
Correct. So that is the only thing that you are interested in. If the child has a prosthetic valve, if the child has got a foreign body, if your child has got a prosthesis or some foreign material stuck inside, you could have a prosthetic valve infection. So in that long drawn out way, it is relevant to what you're asking. Why bronchial asthma?
To know if the child is has an allergic history, or if the child is had previous nebulizations and
No, that I understand. I'm asking, is it in any way related to Sashwant's case history progression is the question. We are talking about a 7-day fever with 2 days of vomiting child. Would this history contribute in any way to our differential? That's all that I'm asking.
No, sir.
Right.
No, sir.
What I would have asked personally is past history of travel, correct?
Yes, sir.
You said offhand what medications he was exposed to. I would like to know definitely whether he was exposed to a particular NSAID, which is capable of producing fever and rash. Definitely whether the child has been on any chronic medication and whether the child has had past history of recurrent illnesses like this. So travel history, family history of similarly affected members, past history of COVID, definitely will be a useful history to ask in this particular child. Okay?
Okay.
Fine.
Treatment history. The child was taken to a private hospital for the above complaints and was treated with oral medications for 3 days. As the child had repeated episodes of fever, the child was brought to GDMCH on day 8 of illness.
Fine. You can proceed.
Antenatal history. Third born to non-consanguineous married parents. Mother's age at conception 30 years. Birth spacing 4 years. Spontaneous conception. Booked and immunized. Had regular antenatal visits. Iron and folic acids taken. No history of fever with rashes or lymphadenopathy. No history of exposure to drugs or radiation. No history of blood transfusion, PAH, GDM, or thyroid disorders during pregnancy. Anomaly scan was normal. TT 2 doses taken. No history of UTI, fever, foul smelling discharge. No history of bleeding or leaking PV during the 3rd trimester. Natal postnatal history. A full-term non-vaginal delivery. Birth weight 0.8 kg. The child cried immediately after birth. Breastfed within 1 hour and no history of any NICU admissions. Developmental history. The milestones were attained appropriate for age. The child can now walk upstairs in baby steps and he can jump. He can turn single pages. He can identify 3 to 4 body parts and speaks sentence with 3 words. Vision and hearing normal. Diet history. Exclusively breastfed till 6 months of age. Takes mixed diet. Required was 1100. Intake 1000 kilocalories. Deficit 100 kilocalories. Protein deficit 2 grams. Immunization history. The child is immunized up to age according to national immunization schedule. No optional vaccines were given. Last vaccine was given at 1.5 years of age. The next vaccine is scheduled around 5 years of age. No history of any allergy to drug or food allergies. Family history. Non-consanguineous married parents. Elder sibling 11 years. Other sibling 6 years. No history of similar illness in the family members at present. Socioeconomic history. Father businessman, mother homemaker, lives in a pakka house with 4 rooms with 2 bedrooms. Uses sanitary latrine. Uses filtered water to drink. No pet animals at home. Vegetations near house. Mosquito breeding places plus. Family belongs to lower middle class according to modified Kuppuswamy classification. No history of contact with tuberculosis or COVID-19. The family. Summary. A 2-year-old male child, third born to non-consanguineous married parents with uneventful antenatal, natal and postnatal history, presented with fever for 8 days and vomiting with no significant past history or family history. The most likely etiology I would like to consider is a febrile illness of infective origin.
Considering the history of 7 days fever, Sahana, when you mentioned the diet history, it would have been useful for you to say whether the baby was exposed to unpasteurized or unboiled milk. Because in the rural atmospheres, it's very common for children to be fed freshly extracted milk. So that might be an important etiological clue for you for brucellosis. It is very common in rural India. So that is dietary history which could have been added on. And you mentioned very specifically about pets. Is there any relevance of particular pets you had in mind? Are there infectious disorders which you can relate pets to? Which pet? Suppose the child had a pet parrot at home. Are you going to think of a particular disease?
Psittacosis.
Very good. So what else? Suppose this child had a pet tortoise or a rabbit or a hamster. Suppose the baby had a pet kitten or a cat.
Toxoplasmosis.
Okay. More important, more common. The condition produces cervical lymphadenopathy with varying combinations of fever.
Cat scratch disease, sir.
Very good. So yeah. So when you write PATS, when you write any history, at least keep 2-3 differentials in your mind, because an astute examiner may pounce on you because you might have mentioned it in the go as a stray point, and you will unnecessarily get into trouble. Okay. So history of pets is important. Toxoplasmosis, toxocariasis, tortoises, the hamsters are very well known carriers for salmonellosis also. Okay.
Yes.
So eating raw eggs, unpasteurized, in recent history of shawarma ingestion also is very important.
Yes.
Yeah. What disease
sir.
was recently associated with shawarma ingestion?
Shigella.
Very good. Shigellosis in Kerala, right? Fine.
Yes.
Good. You're at least reading newspapers. Whether you're reading books or not, you're reading newspapers. I'm happy. Yeah. Can you summarize, Ma?
So 2-year-old male child, third born to non-consanguineous married parents with uneventful antenatal, natal and postnatal history, presented with fever for 8 days and vomiting with no significant past history or family history.
Good.
Can you tell about the fever pattern here, doctor?
So
What is the
fever,
exact fever?
insidious onset, intermittent nature, 1 to 2 spikes per day, high grade, not associated with chills or rigors, no diurnal variation, interfebrile period, the child was active.
Okay, actually, only there is a fever and vomiting only. Why you want to choose infectious disorder only? With history itself.
So causes for fever mainly is infective, inflammatory or infiltrative, sir, in which in our scenario, infective is more common.
And also to rule out anything you want to add, you want to rule out infiltrative disorder or inflammatory disorder. So what is the clue you get here actually?
No other associated inflammatory symptoms. No
Yes,
joint
exactly.
pain, no rash.
Yes, good. Okay.
You can proceed to examination.
Yeah. So can I
sorry,
just ask
sorry.
you? Yeah. So generally, is there any particular examination that you want to do? I mean, I know you will do your phallic presence, cyanosis, and lymph nodes and all that, and the systemic examination. Is there specific any examination that you would like to look for given this history?
Lymphadenopathy.
Okay, lymphadenopathy. Can you tell me why?
Fever associated with lymphadenopathies will have different diagnosis, sir.
Like, can you give me some 3 differentials for, like, somebody comes with fever and lymphadenopathy?
Scrub typhus.
Scrub typhus, sir.
I wouldn't think of that as the first one. Okay.
Leukemias.
Okay.
Leukemia, lymphomas.
Any other common infectious disorder come with fever, cervical lymphadenopathy?
Tuberculosis.
Tuberculosis, sir.
Okay.
Hey, again, we are stressing the point that even according to the NTP guidelines, tuberculosis is a consideration and the fever has been there for more than 2 weeks.
2 weeks.
You are presenting a child with a fairly acute history. It is not wrong to say tuberculosis. Dr. Rose has already corrected you once for saying tuberculosis. Correct?
Measles,
Put
sir.
it down the list.
Fever, lymphadenopathy, post-auricular lymphadenopathy, measles, sir.
Is measles the one which is associated with post-auricular lymphadenopathy or some other infection?
Brucellosis.
No,
fever.
I mean, okay. Post-auricular. Okay, I was talking about rubella.
Rubella.
That's the one which is more likely. No, but that's not the differential that we are considering here. But I mean, that's the one which is associated with lymphadenopathy, not so much measles. Okay. So I would think actually EBV infection as a big one, if you actually think there is fever and lymphadenopathy. So, okay, lymphadenopathy is an important thing to look for. Okay, and you'll have to see whether it's localized or generalized as well. Any other, anything else that you would want to look for?
I do. Sir, eyes, sir, for conjunctival congestion.
Okay, yeah.
Coated tongue.
Okay.
Oral mucosa, coated tongue.
Coated tongue doesn't tell you much.
Any petechial rashes and ecchymus.
Okay, so that's something. So your skin examination is an important one. Okay. So anything else you want to do in the skin examination? You said petechial rash.
Eschar, sir. Look for eschar.
Okay, so that's an important one, because if you actually find an eschar, then your diagnosis of scrub typhus becomes, you know, even more secure. Okay. Do you know where to look for eschar?
Yes, sir. In the cool area, in the groin, inguinal region, axillary region, behind the nape of neck, behind the earlobe.
Okay, so
hidden
a lot of it
areas.
is in skin folds. Yeah.
Yes.
Yeah. So what I'm trying to suggest is that before you start your examination, if you think about what you're going to look for, then it's very likely that you won't miss those things. So it's better to just think about what you want to look for, and then you start your examination. Yeah, please go ahead.
General examination, the child conscious, alert, febrile, no pallor, icterus, no cyanosis, clubbing or edema, no significant lymphadenopathy, hydration fair. On receiving, the child pediatric triangle showed child was alert, awake, airway stable, breathing was rate 22 per minute, no retraction, stridor or grunt, circulation, heart rate 108 per minute, CRT less than 3 seconds, central and peripheral pulses felt, warm peripheries with a BP 80-60, which show that the child was not in shock. Temperature 102 degree Fahrenheit measured in the axilla. Pulse rate 108 per minute, regular rhythm, normal volume, no specific character, no radiofemoral delay, felt in all peripheral pulses. Respiratory rate 22 per minute, regular thoraco-abdominal pattern. BP 80/60 measured in the left upper limb in the supine position. Saturation 99% in room air.
Would you want to comment about that pulse rate, Dr. Ranjani? The child has got 102 fever, and you said the child's heart rate is 102.
Yes, sir.
Can you go to the previous slide? What was the heart rate you said, ma?
102, sir.
102 was the temperature, ma. What was the pulse rate? It was 108, if I'm not mistaken.
Yes, 108 pulse rate, sir. 102 temperature, sir.
Okay. So for 102 fever in a 2-year-old child, is pulse rate of 108 appropriate or inappropriately low? Would you call this tachycardia, appropriate, or relative bradycardia?
Relative bradycardia, sir. For each degree rise in Celsius, 10 beats per minute has to increase.
Yeah, but you have measured it in Fahrenheit, no?
Yes, sir.
So now tell me, in a 2-year-old child, anxious child, you are assessing him in the ER, he's febrile. Do you think his heart rate would be 108? Is that appropriate heart rate? Just for the sake of theory discussion, are there conditions where relative bradycardia has some diagnostic?
In enteric fever, sir.
Where else?
Sir,
recovery phase of dengue.
Very good. So there's a specific name given for that. Would you know what that is? This dissociation between the heart rate and the temperature, it's got a specific name sign to it. Would you know the name of the sign?
No, sir.
It's called Fagett sign. F-A-G-E-T apostrophe S. It's called Fagett sign. Okay. It's not specific for typhoid. It's not specific for dengue. Because I was struck by the temperature, and the child you're seeing for the first time is not only a pulse rate of 108. Okay. Go ahead. Suppose the child had been very drowsy. You have given a history of 2 days of vomiting after 7 days of fever. If the child had been very, very resentful for physical examination, was lying on the shoulders of the mother, whimpering, not looking at you, shutting his eyes closed when you shown a light, what are the things that you would have considered? Child is not alert. Child is very irritable, wants to lie on the mother's shoulder after 7 days of fever and 2 days of vomiting. What is the first?
Meningeal irritation, meningeal.
Very good, very good. Dr. Winsley asked you, no? So whenever you are going to do an examination, already in your mind, you should have some idea what this child's physical examination is going to yield, correct?
Yes.
You will examine thoroughly, but there are some areas where you will get more importance, more attention. All life-threatening illnesses where time is of the essence, that you don't want to miss out, correct?
Yes.
Correct. Please go ahead. Sorry for the interruption.
Anthropometry, height observed 83, expected 89, between the 0 to second score in the WHO chart. Weight, nose observed 10.5 kg, expected 12 kgs. Mid-arm circumference 14.5 centimeter normal, head circumference normal. No stunting or wasting. Head to foot examination, head appears normal, no dysmorphic, eyes appear normal, no suffusion, discharge or cataract, ears, nose normal, oral cavity, no angular stomatitis, dental caries, bleeding comes, no tonsillar enlargements, no pharyngeal wall congestions. BCG scar present in the left side, no skin rashes, eschar, petechiae, purpura, ecchymosis, joint swellings, spine normal, external genitalia normal, no phimosis. Systemic examination, abdominal examination. On inspection, abdomen not distended, flanks free, all quadrants move with respiration, umbilicus in midline, inverted, no visible scars, no pulsations or dilated veins, hernial orifices free, external genitalia normal. On palpation, no warmth, no tenderness, lower border of liver palpable 4 centimeter below the right costal margin, no tenderness, soft in consistency, smooth surface and rounded margins. Spleen palpable in the left hypochondrium, 2 centimeter below the left costal margin, non-tender, moves with respiration, soft in consistency. Splenic knots not felt. Percussion, upper border of liver dullness felt in the 5th intercostal space, liver span 7.5 centimeter. On tidal percussion, the dullness was confirmed to be of liver, puddle sign negative, no free fluid in the abdomen. Auscultation, bowel sounds 5 per minute, normal, no bruit heard. Other system examination, CVS S1, S2 heard, no murmurs, RS trachea in the midline, bilateral air entry equal, normal vesicular breath sounds heard. CNS, no focal neurological deficit or no signs of any meningeal irritation. Summary, a 2-year-old male child, third born to non-consanguineous married parents with uneventful perinatal history, developmentally normal with fever for 8 days, presented was active, on examination was active, febrile, and in systemic examination revealed hepatosplenomegaly. The rest of the examination was within normal limits.
So one of the points that our esteemed judges pointed out is when you have a child who's got a 7-day history of fever with irritability, lethargy, in addition to meningeal irritation, you should also consider dyselectrolytemia and hypoglycemia, especially if it's a malnourished child, because these are all points of characteristics which you should be able to identify and correct in the ER, not in the ward, correct?
Yes.
So there's an additional point that Dr. Rema wants to share.
Yes.
So you mentioned about tidal percussion, no? And you said it confirmed that it was a liver. Can you just describe what is tidal percussion and how you did it?
Sir, we need to percuss the intercostal space, sir. When we percuss from above, we get the dullness at the 5th intercostal space to confirm if the dullness of the liver, we have to ask to inspire, sir. On inspiration, if the dullness turns resonant, then it is a low liver, sir.
Okay, so will you be able to do that in a 2-year-old child?
Asking to hold the breath till you complete your percussion is very difficult.
So so let's say there was the dullness remains. So what does that mean?
Consolidation, sir.
Effusion,
Or,
sir.
Effusion.
Yeah.
Effusion or consolidation.
Yeah, so tidal
Correct.
percussion is typically actually described with effusion,
Pleural effusion.
pleural effusion. Okay. Yeah, I mean, I don't think a 2-year-old it's easy to do this thing. And did you manage to do a puddle sign? How did you do puddle sign?
Sir, we had to put our child on the knee elbow posture, sir. But and you have to percuss from the lateral to the medial, sir, on the abdomen, where you get the
Yeah, I just
dullness.
wondered whether you actually did those signs. Yeah, I mean, see, we're all pediatricians. We understand there are some limitations with what we can do. So I think it's okay to not do some things. And if you're not done it, it's okay to say that you haven't done it. It's okay.
Okay, sir.
Yeah, go on.
So at the end of your after going through the abdominal examination, Dr. Anjani, would you think you are wiser as regards the differential? Are you able to come to some more forms of differentials? Has this physical examination aided you in shortening your list of DDs?
Yes, sir. It has helped us to go into infections with hepatosplenomegaly into our differential diagnosis, sir.
Why would you say again infections, ma?
No, sir.
Have
Any
you wrote-
infection or inflammation or infection with hepatosplenomegaly.
Yeah, that is where we started with. So
Yes.
at the end of it, you said initially you will consider infection, inflammation, infiltration. Now,
Yes,
after you are saying, you are going to say again the same prolonged pyrexia with hepatosplenomegaly, again infection, inflammation, infiltration. So are you telling me that the sorry, come again? Yes.
So more of infectious etiology because of the consistency of liver and spleen appears to be soft, might mostly be due to infectious etiologies.
Mm-hmm.
Any
If
other
it's an
findings?
infiltrative etiology, what would you have expected, ma? Suppose this is
Soft
acute
liver and
lymphoblastic
soft-
leukemia, what would you expect in the liver?
Sir?
Leukemia.
Suppose it's a systemic juvenile idiopathic arthritis, systemic onset. Suppose it's an acute lymphoblastic leukemia. What would the liver have been in those conditions? I've given you one inflammation, one infiltration. What will be the nature of the liver there?
Firm liver, sir.
Why would the liver be firm in systemic onset JAM?
Sir, in systemic onset JA,
Because it is a reticular.
The reticular endothelial system, the Kupffer cells have undergone hyperplasia. They are very
Yes, sir.
angry, correct? So the
Yes, sir.
liver's reticular endothelial system is getting activated. Therefore, the liver is large. Why
Large.
would you say the liver is firm? Is it cirrhotic? Is it a fibrotic liver?
No, sir.
So why would it be firm?
It will be soft.
So you only said firm,
Sorry, sir.
correct? So same also with ALL.
Soft.
Even though ALL is an infiltrative condition, it's basically a cell which ought not to be part of the hepatic parenchyma, is infiltrating the liver. And many of these children also have pallor. So there will be an event of congestive hepatomegaly. So the hepatomegaly in systemic onset JA, in acute lymphoblastic leukemia, the liver is going to be a soft liver. We are talking about firm liver, hard liver only when we are talking about chronic liver disease or a liver that is studded with metastasis, which is not on the differential diagnosis of what we're discussing in a 7-day pyrexia child. Previously well, was relatively thriving well too. Correct?
Yes,
Fine. So can you now summarize all your findings? You have pyrexia, you have hepatosplenomegaly, soft liver, soft spleen, and no evidence of free fluid. Did you see any evidence of chronic liver disease in this child?
No, sir.
No signs of liver
cell failures. No signs of chronic liver disease.
So that is very important because differential diagnosis for a child who's come with fever, hepatosplenomegaly is very different from a child who's got hepatosplenomegaly who also happens to have a fever. Can I just give you another hypothetical case scenario just to highlight this point? Suppose this child is a known patient of Wilson's disease who is very, very non-compliant with chelation therapy, correct?
Okay, sir.
So this child is a known patient of Wilson's disease. He has come with hepatosplenomegaly and fever of 7 days duration. Will your differentials be different here as opposed to what you're discussing for Sashwat?
No, it will be different, sir.
In what sense, ma? Child is coming with fever, vomiting. He is a known patient of chronic active hepatitis because of Wilson's disease. On examination, you elicit signs of ascites. He has got abdominal tenderness.
Liver cell failure, the child is going for acute liver failures.
No, but the child is presented with fever of 7 days and 2 days of vomiting. The point I'm trying to say is a child who had previous hepatosplenomegaly, who's picked up a fever now, versus a child who's got fever, hepatosplenomegaly, all of 7 days duration.
Okay.
Correct. So in the Wilson's case scenario, would you be happy with the child if he came with fever of 7 days and abdominal pain and vomiting?
No, no, sir.
So what would your differentials there be? Will you consider inflammation? Will you consider infiltration there?
For there, my first will be of inflammation and infiltration rather than infection, sir.
It's exactly the other way, Raja.
Sir.
A child with Wilson's disease who is non-compliant with therapy.
Infiltration.
Sir,
the case of Wilson, what is the finding will be? Sorry, is asking. The case of Wilson's disease are not on proper treatment, came with fever for 7 days. What are the possible clinical findings you can see in that child different from this case? This is sir want to ask you. Am I correct, sir? What are the other findings will be there in that particular child? In Wilson's, what are the other findings you may see?
Carefree.
Okay.
Okay.
Signs of liver cell failure if the child is going for liver cell failure.
Okay. The point I'm trying to make is when you see a child with a fever, hepatosplenomegaly, it's very important for you to find out whether it's a child with a fever, hepatosplenomegaly, all of the same etiology, or the child has got a hepatosplenomegaly of an etiology who also happens to have fever. A child of Wilson's disease with poor control of the disease, if he came with hepatosplenomegaly and fever of 7 days duration with vomiting, my differential diagnosis will be spontaneous bacterial peritonitis. I would monitor this child very closely for him to develop hepatic encephalopathy because vomiting, fever, sepsis can all push him towards hepatic encephalopathy. My workup will be targeted towards infection. I will not consider infiltration or inflammation in a child who already has a known etiology for the hepatosplenomegaly. Correct? So you should not waste your time doing unnecessary investigations. You should target your energy in more towards infectious complications. That's what I wanted you to do. Okay.
Actually, it's a known case of Wilson. You are eliciting the from history itself. It's a case of Wilson's, and you know that whether patient is on proper treatment or not. Then what are the clinical findings related to Wilson's available or not? If the Wilson disease developed some complications, what are the possible complications? And with that particular disease will lead to what is the another complication. These are the things you should think for it in the particular child. This is sir wants to tell you that. Okay, are you able to get it?
Yes, sir. Yes, sir.
Right. So how will you proceed to investigate this child, Dr. Shahana?
Sir, first I'll do a complete blood count.
No, Sagana, before going blood count, sir already mentioned, after finishing history, you should try to focus something in examination. Then only you can identify the exact diagnosis. Before going for investigation, you should have some differential diagnosis for this pattern. Then only you can order the investigation what you want. What is the what is the particular investigation? Will try to give the exact diagnosis for your particular case. Okay, try to give some differential diagnosis with this background.
So fever with if a patient is having GI symptoms, then it could be enteric. Then fever with hepatomegaly with I will see for Eschar, sir. Eschar in general examination. Then
Eschar is not here. Okay.
Eschar is not here. Then it can be
In your
scrub.
case, is there Eschar is present or not?
No, sir.
Okay. Without Eschar, scrub is still possible or not possible?
Possible, sir.
How many cases of in scrub you can be see Eschar? Eschar will be present.
30 to 60%, sir.
Why it is not? Is there anything related to Eschar present the case? What is the any relevance?
Severity,
Why
sir.
don't? It's not severity. Okay. Anything else? It is due to Eschar is due to
Sir, multiplication of.
no. I'm asking why Eschar is produced in the children in Scraptypus. What is the reason?
Due to the bite of
the cigar bite. At the bite, there is a cigar burn kind of lesion. Due to the vasculitis and the thrombitis, there will be lesion that leads to eschar, sir.
Is it a painful or not painful? Painless?
Painless, sir.
Okay. Go for any other. You are telling that enteric and scrub. Anything else you want to add in your diagnosis? It's a fever of 1 week, more than 1 week, with soft liver and soft spleen.
Malaria, sir.
Okay.
Can you again classify it, Ma? Can you
Sorry,
classify it as bacterial diseases, then viral diseases, then parasitic diseases, so that your ordering of investigation becomes more streamlined?
Okay, sir.
So tell us, what are the bacteria you will consider in this case scenario? Fever
Enteric
of 7
fever,
days,
sir.
hepatosplenomegaly. Enteric fever you want to consider. Good. What else? Leptospirosis, you said.
Leptospirosis.
What else? Rickettsial diseases.
Yes, sir. Rickettsial diseases.
Cryptyphus.
Yes, sir.
Okay. Is there any other bacterial disease that you would like to consider? 7 days fever, rural atmosphere, hepatosplenomegaly? Always keep brucellosis in the differential diagnosis.
Okay.
Brucellosis starts like this. It's a very, it is common enough for us to keep it in the differential diagnosis. Don't think of it as an esoteric disease, because unless you think of it, you won't ask for the investigation and you will not get the diagnosis. Correct?
Okay. Yes.
So typhoid, leptospirosis, rickettsial disease, cryptyphus, and brucellosis. These were the bacteria that you considered, because we are living in a country where tuberculosis continues to be a scourge. We will keep tuberculosis as the last, just to complete this list of differentials. What about the viral diseases that you will consider with fever, hepatosplenomegaly?
VHF with secondary infections.
No, this you said before. Dr. Winsley corrected you again.
Sorry.
You will consider Epstein-Barr virus first. All right. You can consider Epstein-Barr virus infection. You can consider cytomegalovirus infection. Yes. Even acute HIV can present with a flu-like syndrome of fever, hepatosplenomegaly, and generalized lymphadenopathy.
Yes.
HIV is not always a chronic illness. HIV can present as an acute flu-like syndrome. Okay?
Yes, sir.
Fine. So cytomegalovirus, Epstein-Barr virus, HIV are 3 viruses you will consider with fever, hepatosplenomegaly. What about infectious hepatitis? Could this be hepatitis A virus? Could this be hepatitis B, one of the hepatotropic viruses? Will you consider a hepatotropic virus as the differential in this case scenario?
So
Because you said he is only vaccinated with the UIP vaccines. He has not received optional vaccines. So I assume he has not received hepatitis A vaccine. He has not received typhoid vaccine either. Correct? He's received only UIP, which means most probably hepatitis B vaccine. We don't need to consider HBV as an important etiological consideration. What about hepatitis A virus?
So there will be persistent vomiting in the child, sir, in hepatitis A.
Okay.
The child
So
had
is
only
persistent vomiting
the
the reason you are saying no, or this child does not have a tender hepatomegaly, is not having icterus? Is that more important?
No icterus.
No. Correct.
No icterus, no
and
yellow
it is
urine.
hepatitis. So it will be a tender hepatomegaly, right? In your physical examination, you said it is a soft hepatomegaly, non-tender, correct?
Yes.
So I will not consider hepatitis as an important consideration, because there is no clinical icterus and it's a non-tender hepatomegaly. And splenomegaly in the 7 days history of hepatitis is very unusual. Okay, fine. So you consider virus. What about the parasites that you would like to consider?
Malaria.
What else?
Here, color is not seen.
Correct. But suppose this child went to see his party tata in Jharkhand and came back after a month of staying at Bihar for his annual holidays.
Kala.
Yeah. So you will definitely keep Kerala as a postgraduate. At least you have to keep mentioning it as one of the differences. Anything else? Any other parasite? Fever, hepatosplenomegaly, flu-like illness. Typically, we talk about it only as an IU infection. Mostly we talk about it as an IU infection. You said that when you talked about pets.
Toxoplasmosis.
Very good. So toxoplasmosis also can present as a flu-like illness with fever and hepatosplenomegaly. Okay. Dr. Winsley, any comments from your side, sir? Can we proceed to investigate the child?
Yeah, I think, go on.
Dr. Balaji?
Yes, sir. Yes, sir, they can
Can
go
we
for
proceed to
investigation.
investigate the child? Finally.
Investigation.
No.
Investigations. The total count was 10,300. HB12, platelet count 2 lakhs. SGOT, SGBT, liver function tests were within normal limits. Sodium 138, potassium 4. RFT was within normal limits. CRP was positive.
What does CRP positive mean, ma?
That the child has any active infection or inflammation.
No. What do you mean by CRP positive? What is CRP positive?
What is the value
cutoff?
or anything? Cutoff value.
So in our hospital, more than one.
More than one what? Milligram, microgram, kilogram, hectogram, what gram? Per deciliter, liter? தெரியாதுல்ல உனக்கு? So if you are seeing the reports properly, you always know the units, correct? CRP is measured in milligrams per liter. To consider it positive, you need to have a value of more than 20 milligrams per liter. So CRP positive is any value more than 6. A value of more than 6 milligrams per liter, the lab will say is positive. CRP positive, for you to be clinically significant, it should be at least more than 20 milligrams per liter positive. First of all, tell me why you did CRP, ma, for this child. Why did you do CRP for this child? Why did you not do ESR? Why did you do CRP?
To confirm if it is a bacterial infectious or an inflammatory.
What happens to CRP in juvenile idiopathic arthritis, ma?
It is negative.
What happens to CRP in Kawasaki disease?
Elevated, sir. Kawasaki.
So is
elevated.
Kawasaki an infectious disease?
No, inflammatory disease, sir.
So will CRP tell you it's infection?
No, so infection and inflammation will CRP will be elevated.
Okay. So that's why you did CRP. Would you place CRP more superior to ESR, ma? I don't see ESR anywhere here.
No, sir.
So in a child who is presented with 7 days of fever, would you have considered doing an ESR?
Yes, sir.
Okay, somehow it's got left out. You mentioned the electrolytes. Any particular reason why you did sodium for a child who's vomited for 2 days only?
To see about dyselectrolemia.
Dyselectrolytemia.
No, actually it's a case of fever, only 2 days vomiting. What is the significance of doing electrolytes in that particular case? In your differential diagnosis, any case will cause electrolyte imbalance?
Leptospirosis will cause hyponatremia, sir.
Very good. What other disease causes hyponatremia?
Sir?
What other disease? You are right. Absolutely right. What other disease would you consider if you have hyponatremia, especially if it's associated with hypoalbuminemia also?
Scrub typhus.
Very good. Rickettsial disease. Don't get this idea that scrub is the only rickettsia. In fact, it's not rickettsia. It's Orientia susugamushi, right?
Yes.
Scrub typhus is no longer under rickettsia. Rickettsia is different. Orientia is different. So consider always rickettsial disease and answer scrub typhus separately. Okay, don't club them together. So yes, you are absolutely right. Hyponatremia can give you an etiological clue for leptospirosis as well as rickettsial disease, also for strep typhus.
Yes.
Correct?
Yes.
Can you comment about this total count, ma'am? Is this total count normal?
Mild leukocytosis is this.
What is
No, what
mild,
is the
moderate, and severe leukocytosis? Can you clarify? What is this mild leukocytosis, ma'am?
No, sir, normal, sir. Total count normal.
Yes, thank you. That's a much better answer. There is no leukocytosis.
Okay.
What about the hemoglobin, ma'am?
Sir, it is normal.
Normal only.
Very good. What about the platelet count?
Normal,
sir.
above 1 point.
So if the platelet count is 212,000 on day 7 of a febrile illness, what infectious disease become less likely?
Dengue and
Dengue, sir.
Viral hemorrhagic fever becomes less likely.
Less
What
likely.
else?
Strep typhus.
Very good. Rickettsial
Strep
disease, strep typhus, both of them become less likely. Even typhoid produces a mild drop in platelet count, but not of diagnostic importance. Correct. So you said the child has got a 7 centimeters liver with a span of 7.5 centimeters non-tender. Your SGPT, would you comment about these values? Are they appropriate?
Due to hepatotrophic virus.
Not due to hepatotrophic virus.
So you can say there is no hepatitis.
Yes, sir.
Can we say that?
Yes, sir.
Yes, sir.
Yeah. So it's an enlarged liver, but it's probably not an inflamed or infected liver because the liver enzymes are back normal.
Normal.
Correct. So the child is not vomited, therefore too much to cause a dyselectrolytemia. Any comments about the urea and creatinine?
It is normal, sir. In leptospirosis, you can have deranged renal parameters.
Not deranged renal parameters. Creatinine tends to be on the
Creatinine
highest
will
side.
be elevated.
Okay. So what is missing in this investigation, ma'am?
Urine routine, sir.
What else? ESR.
ESR, sir.
Yes. So ESR and
Differential count?
CRP tend to go together, but there are conditions where ESR is more elevated. There are conditions where CRP is more elevated, and they have diagnostic significance. So please order HB, CBC, always ESR first, and then CRP later, because CRP is very prone to overinterpretation. I think too much of importance is given to CRP. If you're talking about Kawasaki, MIS-C, if you're talking about inflammatory disease or invasive septicemia, or you're screening a newborn for possible bacterial sepsis, CRP is a good screening tool. Correct? In a 7-day community-acquired infection in a child who was previously well, I would not give too much of importance to CRP. One of the explanations of CRP is correlate rationally, please. Correct? Don't blindly go after CRP and treat elevated CRP with ever escalating antibiotics. Okay?
Yes.
Any reason you didn't include differential count?
No, sir. We should include, sir.
Yeah. So
Is it
any
done or not?
clues
Yes,
that you
done,
can get
sir.
from a differential count? I'm sure it would have been done. Any clues that you can get from a differential count?
Yes, sir. In
Typhoid neutropenia will be there, sir. Eosinopenia will be there, sir.
Okay.
Lymphos.
Yeah.
Infectious mononucleosis,
Lymphocytosis.
Okay. So you can get atypical lymphocytes with Epstein-Barr viral infections. Okay. Anything else?
Bacterial increased neutrophil counts.
Okay. Yeah. So I think the eosinopenia, I mean, it's more like if you have more eosinophils, it's less likely to be typhoid, because even with any bacterial sepsis, you can have eosinopenia. So, but if you have more eosinophils, it's less likely to be typhoid. That's what it means. And yeah, lymphocytes you mentioned. Yeah. So please continue.
The child came with fever with thrombocytopenia. What are the differential diagnosis you consider in your mind? Apart from your case, I am asking fever with thrombocytopenia.
VHF, sir.
VHF means viral?
Viral hemorrhage.
Dengue.
Okay.
Rickettsial infection, strep typhus.
Okay.
Malaria.
Enteric fever.
Okay.
Sometimes in malaria.
Okay.
Sepsis, sir.
Missy.
Even
Okay. Sir already mentioned you can divide into infection, inflammatory, infiltrative. So that's like you can divide it.
okay, sir. Even
Okay.
leukemia can present
Any
with bicytopenia or thrombocytopenia, sir.
okay. Any viral illness? Any other viral illness? So far discuss.
Infectious mono.
Good.
No.
Epstein Barr.
Any fever with rash?
Chikungunya.
Measles.
Yes, good. Any other condition? Anyone other infective conditions? Fever, hepatomegaly, jaundice.
Leptospirosis, sir.
Even you can get in leptospirosis also. But though it is present in all conditions, what is the typical finding seen in dengue? How will you say it is?
Thrombocytopenia will be there in dengue.
Sudden fall in thrombocytopenia, platelet counts. Drastic fall in platelet count.
Along with
raised hematocrit.
Hematocrit
and
elevation.
leukopenia.
Yeah, you should consider in that scenario you are dealing with. So dengue, where there is a capital leak is predominant, the child may go for shock. Okay. In scrub, you are doing all the investigation. In scrub types, along with thrombocytopenia, any other investigation among the CBC will help you to identify any other thing?
Leukocytosis will be there.
Leukocyte, total count, sir. Leukocytosis.
Okay.
Anemia.
Anemia.
Yes, anemia may be there. As already mentioned, there is hypoalbuminemia, hyponatremia.
Hyponatremia.
So those things will help us. Okay, you are putting investigations SGOT and SGPT. So these investigations may be elevated in dengue, scrub, and typhoid also. But as SAR is mentioned, it may be elevated in viral hepatitis also. How will you differentiate whether you are dealing with hepatotropic virus or something, some other infection causing elevated liver enzymes?
Whether SGOT or PT is more elevated, we'll see, sir. If it is SGPT more elevated.
Okay. SGPT elevated in which condition?
Hepatotrophic viral conditions, sir.
Okay. SGOT?
Otherwise,
other non-hepatotrophic infection conditions, SGOT will be elevated, sir. More.
Dengue, okay. What is the cause for dengue causing hepatitis? What is the important? Why is the dengue causing hepatitis? What is the reason?
Antibody mediated reaction over the liver cells.
Anything else?
Liver congestion, sir.
No. What will happen in dengue?
Capillary leak.
What is the basic pathophysiology of dengue, ma? What is the target organ for dengue virus?
Endothelium causing capillary leak.
What will happen next after capillary leak?
Congestion, sir.
No. Capillary leak will lead to what is the problem?
Third space fluid collection.
Okay, third space fluid collection. What is happening in the vascular area?
Intravascular volume reduction, sir.
Yeah, that's condition called
shock.
Shock.
Yes, a shock.
Okay, in shock, what will happen? There is decreased circulation to the
liver.
So it is, yes, so decreased circulation of all the organs. That's also main thing. Okay, you have to consider. Okay. Will you consider dengue in this case? In a clinical scenario?
Fever is present even after more than 7 days, sir. Dengue, mostly it is biphasic fever, where in critical phase, the child will not have fever. but we can consider
Dengue might be considered last because
Also
of
observed.
normal platelet count and the pattern of fever patterns. And the child is still well looking even on the 7th day of fever.
Okay, will you get in dengue both hepatosplenomegaly or only any one organomegaly?
only hepatomegaly, sir.
So it is unlikely to be dengue in this particular background. Okay. Then how to proceed further?
So the next
So
line
you
of
are
investigation
okay.
were done, sir.
Hmm. What
Vidal
are
negative.
investigation?
Before you go to
IBM
Vidal, ma, along with CBST, why not peripheral smear study, ma?
It was done, sir.
So tell us what the peripheral smear studies show. Tell us why it's important. Of all the diseases that you considered in the differential, what are the diseases that a simple peripheral smear, a good pathologist can pick up for you?
Malarial parasite.
Very good. What else? If all the
Last time
platelets are clumping, you are on the smear seeing lots of platelets, they are getting clumping and forming pseudo rosettes. But the platelet count in the patient, when you do manually, it's coming low. But when you see in the peripheral smear, lot of platelet clumpings are seen, giving rise to the impression that the platelet count is low. It's not actually low, they are getting clumped.
Rickettsial infection, sir.
Very good. So clumping of platelets can give you a clue.
Pseudothrombocytopenia.
Malarial parasite can give you a clue.
It is
What
called
Pseudothrombocytopenia.
okay.
Correct. What else, ma? What else can the peripheral smear guide you?
Blast cells
Suppose
for
it showed toxic granulations and lots of shift to left. You have a neutrophilic leukocytosis with lot of toxic granulations and the shift to the left. CRP is positive. Suppose counts is 25,000.
leukemia.
You will have to consider bacterial sepsis. No?
Okay.
There is
Yes.
leukocytosis, there is a shift to the left. Neutrophils are looking extremely agitated. There's a lot of toxic granules, correct? All these
Yes,
are
sir.
pointers which will guide you towards a probable invasive bacterial disease.
Yes,
Okay?
sir.
So peripheral smear is a very, very important test. Can you proceed, ma?
Yes,
What
sir.
else did you do for this child?
Sir, IgM dengue was done, which turned to be negative. Vidal was negative. Peripheral smears was normocytic, normochromic, no hemoparasite specific seen. IgM scrub turned out to be positive. Urine routine was normal. Culture was sent, which showed no growth.
So you considered still dengue as the first, that is the first investigation you have written, ma?
No, sir. Not
You
in
still
any
managed to do the dengue. Correct. You said dengue is unlikely, but that is the first thing you have put up. I'm sure we all keep doing these panels. But if you are a betting person, would you have done dengue as first, or which of these tests you would have asked for first? Because you told us very
Vidal and
clearly it is
IgM
unlikely to be dengue. Correct?
Yes, sir. Yes, sir.
Hmm.
Vidal, IgM scrub, peripheral smears.
And a blood culture.
Blood culture. Correct. Fine. So what is your final diagnosis now?
Scrub typhus.
Okay. So would you know of any criteria that is devised by one of our Indians which tells us what is the possibility of having a rickettsial disease based on certain criteria, clinical criteria, lab criteria? Would you know of any criteria? Yes, no?
Yes, sir.
Yeah. No, Fain's criteria, modified Fain's criteria is for leptospirosis.
Leptospirosis.
My question to you was about rickettsial disease. Are you aware of any criteria?
No,
One
sir.
of the authors is an Indian, so it is a matter of pride for us to know that we have contributed to world literature for making a
No, sir.
tropical disease diagnosis. It's called Rathi, Goodman and Agai criteria. This is otherwise called RGA criteria. That is a scoring system which increases the probability of making a diagnosis of rickettsial disease, very specifically streptitis. Okay, so different points are given scoring, rural or urban, whether there's a history of exposure to ticks, whether there is a tick bite, whether there is a star, whether there is hypoalbuminemia, whether there is thrombocytopenia, whether there is elements of hyponatremia. So all these are given scoring points. So at the end of the scoring, if your Rati, Goodman and Agai scoring points are in more than 25, it gives you a high probability of having a rickettsial disease. Correct? So because all of us don't have access to Weyl Felix, and Weyl Felix is not a test that we routinely use to make a diagnosis of rickettsial disease. It is probably as valid as Vidal. Textbooks continue to write both Weyl Felix and Vidal should be consigned to the dustbin, but we in our country will continue to use it for at least in the foreseeable future. So you should remember Rati, Goodman and Agai criteria for rickettsial disease. Okay?
Yes, sir.
Fine. Can you proceed?
The child was treated with doxycycline. After 24 hours, the fever settled on day 3 of admission. The child was discharged with oral doxycycline. At review, the child didn't have fever and hepatosplenomegaly regressed.
Why was the child given ceftriaxone?
Sir, initially when the child was admitted, our differential diagnosis was Vidal also, sir. Enteric fever. Enteric fevers.
Okay. So you started enteric fever treatment and doxycycline, or you started ceftriaxone and stopped ceftriaxone and added doxycycline?
So
suppose
here
this child vomits doxycycline repeatedly, what other drugs could you have tried for rickettsia for scrub?
azithromycin.
What else?
IV doxycycline.
IV doxycycline is available? I didn't know that.
Yes.
Yes, sir.
It's available, no?
Yes, sir.
So azithromycin macrolides are one of the other alternatives to do it. Would you have considered doing a rapid diagnostic test for malaria in this child, ma? Rapid diagnostic test.
Yes, sir. Yes, sir.
So which is superior, a peripheral smear study or a rapid diagnostic test?
Rapid diagnostic test is equally good as a peripheral smear, sir.
In what sense, ma? Which has got better sensitivity?
RDT has better sensitivity, sir. Yes, sir.
As compared to peripheral smear, ma? Where does a rapid diagnostic test score over a thick smear, thin smear? Where does a thick smear, thin smear score over a rapid diagnostic test? Because in another 2-3 years, you'll all be having your own clinics, having your own practices, and you will be doing only rapid diagnostic tests. None of you will be answering questions like this. So I want you to be aware when you become pediatricians about the validity or the fallacies of each and every test you do. Correct?
Yes, sir.
You'll be under tremendous pressure to do rapid diagnostic tests because it is like Maggie noodles. You get the answers immediately. 2 hours may fatak say you want answers. Correct? Nobody has the time to watch 5-day test match now. Everybody wants T20, immediate results. So rapid diagnostic tests are good because they have specificity. They have a rapid turnaround time. They don't have the need for laborious looking at 100 fields and things like that. They have acceptable sensitivity and specificity. You can make a differential diagnosis of Plasmodium falciparum, which is capable of producing more complications. So these are the advantages of using a rapid diagnostic test. The disadvantages, even after you have treated for nearly 28 days after the treatment is over, these patients will continue to be having rapid diagnostic test positive. So if you've treated a child with malaria, he goes home and comes back with fever in 7 days' time, you cannot keep repeating the same test. So that good old smear only will tell you whether you cleared the hemoparasite or not. So old is still gold in some ways. Correct?
Yes.
So you should know the advantage of the thick smear, thin smear over the RDT. Everything that is novel and new is not better than the old.
Yes.
Do you understand what I'm trying to say?
Yes, sir.
Yeah. Anything else? Any parting comments, Dr. Winsley, Dr. Balaji?
What is the dose of doxycycline you are using in children?
2.2 mg per kg per dose or 5 mg per kg per day.
Can you use in children? Usually doxycycline is contraindicated children. Usually it is a common thing every textbook tells. Will you use the doxycycline less than 8 years?
Yes, sir, we can use only if it is a prolonged use, you get complications.
So is there any so there is recommendations that doxycycline can be used in even children less than 8 years.
8 years.
So you can use it. So there is no specific contraindication. So it is used in rickets illness. Okay.
Yes.
So will you use in dengue? Doxycycline is used in dengue. Any idea?
It can be used. Can be used.
What is the possible thing? What is why it is used in dengue? What is the mode of action? What is how it is helped in dengue? Any idea?
For thrombocytopenia.
No thrombocytopenia. Thrombocytopenia automatically reverts to normal in recovery phase once the child is coming out of the critical phase. Okay. There's some immunomodulator action also, doxycycline. That's why it is somewhat helpful in dengue. Okay. Okay.
Yes, sir.
So when.
So how do you think this child got scrub typhus?
Sir, from at his home, sir, there are vegetations around his home.
And Dharmaburi is endemic.
It is here. It is endemic for scrubs, sir.
And what was the vector?
Trombiculoid mite.
Okay. Trombiculate mite, yes. Do you know what mite it is? Or what's the common mite which causes scrub typhus?
Chiga's trombiculoid mite.
So
what's the genus name?
Orienta Sushigamushi.
That's the causative organism.
Yes, sir.
We're talking about the vector. The trombiculate mite that you mentioned. I mean, so what is the common genus which actually causes, which transmits scrub typhus? It's usually Leptotrombidium. Leptotrombidium deliens is the commonest one, but Leptotrombidium, this thing. So you mentioned the chigger, no? So what is a chigger? Do you know the life cycle of the trombiculate mite? What is a chigger?
So the larval stage of a trombiculoid mite.
Okay, that's correct. Yeah. So the trombiculate mite itself has has a certain stages in its life cycle, and for it to actually take, for it to mold from one stage to the other, it's a six-legged larval stage, and then from that stage it has to become a nymph. So before that, it needs to take one of these skin meals. Usually, it takes from a rodent, but since the human comes along, then it takes it from that person, and then that's when it transmits the mite. So do you know which is the reservoir for scrub typhus?
Rodents, sir, rat.
Actually, this reservoir is actually the mite itself.
Okay.
The mite itself. So once the mite gets infected, the mite, across generations, it remains infected. That's why you have certain areas where you have these mites which are there, and you get mite islands where you'll have increased scrub typhus. But otherwise, so that's the usual thing with these mites. Do you know how big they are? Have
you can't see with normal eyes, sir.
Sorry?
You can't see with normal.
Yeah, it's about 0.2 mm. It's like a speck of dust. It's very, very small. It's like a speck of dust if you were saying. So I think the important thing is if you ask somebody for a bite, they'll never know because it's painless and the mite is also too small for you to actually recognize. So anyway, so those are the reasons why you would, why you need to actually strip somebody down and look for an eschar, and you cannot ask the patient to actually tell you whether they've been bitten or whether they've got an eschar at somewhere. Yeah. So yeah, I'll stop there.
Quickly, Sheryl, can you quickly tell us what are the complications of scrub typhus, ma? I mean, this child got away lightly. What are the things that could have gone wrong? This will probably be the last question because we are going to wind up in another 3 minutes time.
ARDS.
Can you go system-wise? Cephalocaudal, don't give haphazard answers.
Yes, sir.
Can you go from above downwards?
Meningoencephalitis, sir.
Very good. Encephalopathy.
Yes, sir.
It doesn't demonstrate neurotropism, no? So the basic pathology is always, it is tropic for the vascular endothelium. So almost everywhere it is vascular injury. Fine. So it can produce encephalopathy. What else? Lungs?
ARDS.
Very good. Heart?
Near to lung. Near to lung, what is that?
Sir.
Yes, tell.
Myocarditis.
Okay.
Cardiogenic shock. What about
shock?
In the reticular endothelial system, can streptyphus produce some complication, no? Devastating complication? With hyperferritinemia, hypertriglyceridemia, bicytopenia, tricytopenia. What will you think of if a child comes with fever, hepatosplenomegaly, ferritin of 20,000, hypertriglyceridemia? Very good.
Yes.
HLH, correct. It can cause multi-organ dysfunction syndrome. It can cause meningoencephalopathy. It can cause myocardial cardiogenic shock. Yes, it can cause a septic shock. It can mimic dengue feature for feature. Correct?
Yes.
It can also cause ARDS. You're absolutely right. Right, thanks.
Dr. Balaji, can you stop slide sharing?
Just a minute, sir.
Yeah, please. Yeah, thank you.
Super.
On behalf of IAP TNC, thank Dharmapuri Medical College was presentation, and since they are endemic for subtypes, and I request Dr. Winsley to summarize and concluding about this.
So I think the three of them have actually done fairly well with their differential diagnosis and their history. I think they went in a relatively systematic manner, and it was I think they discussed well as well with all their comments to the questions that were asked. It was I can actually invite some of the judges to give their opinion, because probably that will be a better way to do it. Can I ask one of the judges to actually give their opinion, and then we'll wind up?
Yeah, Dr. Srinivasan sir, please. Dr. Srinivasan sir.
Why not Rama madam started today?
Okay, Dr.
I am starting.
Thank you, sir. At least I have my comments will be having some novelty. Usually, I'm the last one, and I'll always be looking like I'm, copying others. This particularly, it was a very, very, what shall I say, a big learning experience. We always think that. Fevers, what more can somebody discuss? We had a discussion about a couple of weeks ago, and today you had taken it in a totally different direction. I enjoyed it and learned a lot of points today as well, like in every class that we do. And Ashwath particularly, I liked all the questions, very practical. And of course, Dr. Winsley came up with some quips in between, and Matt really it was very complete and very comprehensive. And that scoring system, is it still used, Dr. Ashwath? It is an old one, isn't it? That Rati Goodman thing, people still, or
it is there in the Indian Pediatrics IAP Committee on Management of Rickettsial Disease, is written by Dr. Ratima.
Okay.
So I find it very useful to teach it to the PGs. At least at the postgraduate level, if there is an Indian name to it, and it's
the existence of a score, as you said, particularly if there's an Indian involved, there's all the more reason why we should know.
Correct.
Extremely a very brilliant discussion by all of you. Thank you so much. And the PGs also, they managed to initially, they were, because of this technical glitches, thrown out of gear, but finally they came back and did a good job. Good. The Dharmapuri trainees and trainers did a good job. Thank you.
Thank you.
Thank you, madam. Dr. Janani, madam. Dr. Janani. Dr. Ramesh.
Yes, sir. Except for the small technical hitch, it was complete in every aspect. Both the presenters as well as the moderators and chairperson did a good job. I have two suggestions to make to the secretary, sir, if you don't mind.
Yeah, please, sir.
Sir, these Zoom meetings, some of the students come for the first time. I suggest that they have a trial Zoom meeting one day before in the morning, along with the host college faculty. So, and all the presenters can be ready with the slides, including the local host, so that there is a small hitch, the other one can immediately take over. It will also, the stage fear also will go away with the students once they practice it again. So they can have, it is almost like a conference call these days. They can make within 5 minutes, they can make a Zoom presentation. And second thing is about the discussion of the cases. It is a teaching session, not rightly an exam, and we are not going to give marks. So what I suggest is, time is arbitrarily divided between history, gender physical examination, systemic examination, differential diagnosis, management, complication, and discussion. So that most of the time, history taking takes most of the time. And they do lot of students do a lot of negative history. See, too much of information kills information. So they can ask so much when they are handling the patient. But once they present, they must edit and give only positive findings that is going to help them in the diagnosis, and negative findings that is going to rule out important differential diagnosis. This I have been stressing from the beginning, and this will be overcome if the local host has a trial Zoom meeting in their college. Thank you, sir. Thank you for the opportunity.
Okay, sir. Actually, this is conducted from a digital IAP, sir. The central IAP. Okay, this is not IAP TNSC, what we are today's program. And actually, we are CME as well as practicing pediatrician program. We are conducting through IAP TNSC website. But this is actually conducted by DIP. I will inform the DIP, sir. We will arrange it.
Yeah, it's an excellent. It's going in an excellent. We'll take it to the higher level. That's what my.
Okay, sir. I will.
It's perfect. What's going on is perfect. And today's session was excellent. Every aspect complete.
Yeah, Dr. Janani, madam. Yeah. Dr. Srinivasan, sir.
Yeah, when such Pandits have already mentioned Dr. Rama and Ramesh, what else for me to say? Of course, when Winsley Rose and Balaji and Dr. Ashwath are there, kalakkamatanga, kalakkitanga. So everything has been. Of course, peripheral smear, of course, Ramesh has also mentioned. So peripheral smear, naturally, malarial parasite is the first thing to do in any child with soft hepatosplenomegaly and fever. So peripheral smear, they have just mentioned and allowed us to ask question. Of course, I saw in the chat box, Ramesh has correctly mentioned. And of course, subsequently, it was mentioned by Ashwath. There are so many things that can be derived from peripheral smear study.
Peripheral smear also helps in hemolytic process going on. The immature cells there. So a lot of things, even
even in peripheral smear, in Kaladhar, in Bihar and other places, we can see Donovan bodies.
Viral infection. They can
it's
see
not
the
necessary that we have to do bone marrow. So
platelet aggregates also can be seen. Even you need not rely only on the counts.
It's very well discussed, and excellent inputs have been there. And it's a learning experience for all of us. Thank you so much.
Thank you, sir.
Thank you, sir. Yeah, Dr. Ashwath. Yeah, Dr. Ashwath, please.
No, I think I have nothing more to say. I will thank Dr. Rajendran and Dr. Babu and Dr. Gopal for having me had as a moderator. So these PGs come across as very dedicated and motivated. And special thanks to Dr. Balaji for saving the session by quickly organizing an alternative way of presenting. After that initial 15 minutes, I think everything became very smooth. I would really like to congratulate Dr. Rajendran for being the mentor for this particular postgraduate program, which is there in the digital archival form. Every exam going PG should have a treasure trove of information which is there. It is not easy to run this show for 2.5 years consistently with excellent faculty, with very case scenario, which is so important for the exam going PG point of view, and even for practicing practice.
To smile and acknowledge.
So this is absolutely wonderful thing to be part of. I'm so grateful for the organizers for having me as one of the moderators. Thank you, and well done to the postgraduates and the trainers. Well done. Thank you. Thank you.
Thank you, sir. Yeah, Dr. Balaji, yeah,
Thank you,
please.
sir. Thank you, sir. Sir, thank you, sir. Thank you for giving us the opportunity. Whenever we are discussing case, when we are adding different faculty, they're adding some more valuable scientific material to every PG student. That's very important. So for the past 2.5 years, we are seeing every meeting, every student learning something, because every person will give within particular time. They are adding some more teaching relevant point to the particular case. So it means Katrade Kayalavu Kalada Ulalavu, as I already mentioned, even not only students, I think everybody is learning. That much learning materials given to everybody. So this very wonderful discussion. So I have to thank our all our IAP president, sir, secretary, sir, and all our respected judges, and Ashok sir and Vincent Rose sir adding more points and teaching very nice material today. So on behalf of Dharma Medical College, we thank everybody for this nice occasion. Thank you very much, sir. Thank you, sir.
Yeah, thank you, sir. On behalf of IAP TNSC, I thank today's chairperson, Dr. Winsley Rose. He's an excellent person, and actually he's observing others too, Dr. Balaji as well as Dr. Aswath discussing the case. And really, Caliburn is waiting and seeing what they're really doing. And I think it's really great. And the honor Dr. Winsley Rose is here. And thank you, sir. And I thank my colleague and my friend, Dr. Aswath, has discussed extremely very well for this wonderful case presentation. And I thank Dr. Balaji. I think he's one of my hard-working person, and ever into, I can say. And whenever we are telling the program, he immediately will arrange, he will do it. And really, in IAP TNSC benefited. He has done a lot of teaching program as well as from start with COVID. And he has done a lot of teaching program to IAP TNSC. I really thankful to Dr. Balaji. I thank all our judges. Start with Dr. Srinivasan sir, Dr. Ramesh, and Dr. Janani, Dr. Rama madam, and everybody. I think they participated. And today PRCs are held up. And they have done extreme very well for sitting almost 2.5 3 hours now that freeze the program, and continuously every Saturday. I really thankful to them, and I thank all the postgraduates. I think they are.
Sir, you must always ask the postgraduates what they feel. You are asking judges what they feel. But what is important is the viewpoint of the student. Here afterwards, you make them also answer first before you ask judges, etc.
What can they say? What can they say?
PG is not. I can come on.
They can judge us.
They should tell the experience they have. How it is going to helpful.
Yeah, PG.
Yes, sir.
Yeah, your comment, please.
Feedback.
Sir,
what does this labor? So much of labor is put by Dr. Rajendran for so many weeks. And he is such a busy
thank you so much, sir.
So you should tell what is your opinion about this type of it.
Thank you so much, sir. It is so informative for us. We could be able to learn so many new things by these sessions, sir. Even after the session is over, we have the videos in the YouTube, which helps us to learn all the topics, sir.
Yeah, really thankful to all the postgraduate who took a lot of interest to present the case. And once again, on behalf of IAP TNSC, thank one and all for this wonderful opportunity. Thank you, one and all. Thank you.
Thank you, sir.
Good night. Thank you. Good night.
Thank you, sir. Thank you very much.
Thank you,
sir.
Good night, all of you.
Thank you, sir.
We'll meet again. Thank you.